All right. Good morning. I'm calling this performance oversight roundtable to order. I'm at-large Councilmember Christina Henderson, who's chair of the Committee on Health. Today is Thursday, February 20th, 2025. We are in room 120 of the John A. Wilson Building. The time is 9:41 a.m. Today we will be discussing the performance of the Office of the Deputy Mayor for Health and Human Services and the Department of Healthcare Finance for FY24 to FY25 to date. Due to the snow last week, we divided the hearing up. So we heard from public witnesses last Wednesday, February 12th, and today's hearing will only be for our government witnesses from DMHHS as well as the Department of Healthcare Finance. We're going to start with the Department of, the Office of the Deputy Mayor for Health and Human Services, which supports the mayor in coordinating a comprehensive system of benefits, goods, and services across multiple agencies to ensure that children, youth, and adults with and without disabilities can lead healthy, meaningful, and productive lives. DMHHS provides leadership for policy planning, government relations, and communication and community relations for the agencies under its cluster. DMHHS also manages two special initiatives, Age-Friendly DC and the Interagency Council on Homelessness. It also oversees the administration's encampment cleanup efforts and closure program. Just to sort of forecast where we're going to go, we'll start with DMHHS. We'll take a break. We'll allow for you guys to reset, and then we'll go on to Department of Healthcare Finance if that works for you. I don't see any of my colleagues here, but if they do join us, we'll certainly turn to them for questions and opening statement. The committee did send written pre-hearing questions to the agencies, and we'll reference those materials today. If anyone is watching and they're trying to look for those materials, they can be found on the DC Council website at dccouncil.gov/hearings. They are attached to the first hearing from the one last week. With that, before you begin, Deputy Mayor Turnage, I do need to swear you in, or anyone who may testify today. So if you can, this is for DMHHS. So actually, let's do it for both, so we only have to do it once. So if you or any of the members of your team who may testify today, if you could raise your right hand. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth? Great. All right. When you're ready. Oh, you just got to turn your mic on.
Good morning, Chairwoman Henderson and members of the Committee on Health. I am Wayne Turnage, and I serve as both the Deputy Mayor for Health and Human Services, as well as the Director of the Department of Healthcare Finance. This portion of my testimony focuses on sort of the last 15 months, including the first quarter of this fiscal year. If you would, I have a slide show as opposed to written testimony, which I have submitted for the record. If you would turn to slide 4, it outlines the organizational chart for the Deputy Mayor's office, including, and I will say that the staff is just exceptional, headed by Chief of Staff Kiana Creighton, who's here with us. I have a Deputy Chief of Staff of Encampment, Jamal Weldon, who is on leave for a moment, taking care of some medical issues. I have a Policy Director, Brian Harrison, and a Policy Advisor, Jane O, and a Communication Director, Rebecca Dooley. Unfortunately for my office, we are about to lose the services of Jane O, who is one of the most dedicated professionals with whom I've had the pleasure to work, and she's moving on to another opportunity within DC government, and we will miss her greatly. In addition, I want to acknowledge Ben Stutz, whose work on the new hospital has been fabulous, as he serves in the oversight role and a coordination role for this really, really important project. As you mentioned in your remarks, the Deputy Mayor's office plays an essential role in the executive leadership and coordination of the district's health and human services cluster. My testimony will focus on the performance of DMHHS, thereby leaving the specifics of the policy operations at the other agencies in the cluster to those agencies in their respective performance hearing. To this end, my testimony will address the activities of several specific initiatives that have been spearheaded by DMHHS over the most recent performance cycle. And I would like to place a special focus on the work of the DMHHS policy team, the encampment response, age-friendly DC, and of course the new hospital. If you would turn to slide 6, we have some policy highlights that sort of touch on the work of some of the agencies of which we provide some coordination and oversight. CFSA has launched soft launched their 211 warm line. And this warm line serves as a comprehensive unified social services resource. So it's really a referral center for all district residents. And you can call the 211 line and be connected to social service related information. And you can receive additional assistance from a community responder to help you navigate the services across the city. We expect a full public launch of the warm line this month. Also, DBH has successfully, as you know, opened the district's first stabilization center. This was done in fiscal year 24. The center provides 24/7, 365 days of free access to address the behavioral health crisis that we are experiencing, as with most jurisdictions in the country. They also provide stabilization and medical services to residents struggling with alcohol and other drug addictions. Since its October launch, there have been over 6,888 admissions. They've served a unique number of 2,384 individual residents. And about a third of these residents have accepted referrals to community-based services upon their discharge. DBH continues to collaborate with the district and their community partners to open a second center in Ward 1. I want to skip to slide 7 to touch on some of the highlights involving DC Health. Most specifically, they've implemented a new school health staffing model to ensure that every public school student at a school with a health suite has access to a qualified health professional at their school. They've also made significant changes to licensing pathways to allow those with social work degrees to obtain a licensure via an apprenticeship, and they've also successfully transitioned our animal services to a new provider. That was a robust effort. The previous provider had been around long before I even came to the district, and it was a challenging sort of first responsibility, one major responsibility for the then new director, and she did a wonderful job. We also opened the Afton, and this is something that DMHHS and the mayor and the city administrator are very proud of. I want to thank Sakina Thompson for providing the legal advice and legwork we needed to get that project across the finish line. She did a wonderful job. And this is a huge step in our continuing efforts to address the really challenging and vexing issues associated with homelessness. And then finally, I note that Cedar Hill will open in a couple of months. And this will be a major step in the stride to provide an integrated system of care to the residents of Ward 8, a system of care that they have not seen in its history. They will be a part of a larger system run by GWHS that will provide them at full access to a host of medical services based on their needs. At this time, I would like to turn to slide 10, which focuses on the always difficult issue of encampments that has been spotlighted for at least since I've been in this job. As you can see from this graphic, that we've made significant progress, I believe, in addressing the encampments. I will say out front that the mayor's desire is that nobody lives outside. She thinks in a city, a world-class city in which DC is, in a world-class country, which we are, there should be nobody forced to live outside. Now, that is the goal. There are some challenges that we have to face to try to carry out that goal. But we have reduced the number of encampments from they peaked at 105 in November of 2023. They now, as of December of last year, they sit at about 81. I think the number has decreased some more since as we speak. Most of the encampments still remain in wards 2 and 6, and we work assiduously to try to abate this very difficult problem. And our work on that will continue, obviously, as we hopefully get out of hypothermia season and get into weather conditions that allow us to increase even more the work that we're doing on encampments. If you look at slide 11, this summarizes the encampment team response. We've had 367 engagements. For some reason, the number of site closures is listed as 24, but on the graph next to on the right, it shows we've closed 36 sites and MPS has closed 10, so that's really 46. So I'm not sure. Keon and I were trying to figure that out late last night to no avail. But I trust the numbers on the right a little bit more. We've closed 36 encampments, and I don't. When I say we've closed them, I don't take any pride in going in and shutting down an encampment. We don't do it just because it's unsightly. We do it because in many cases it's unhealthy, and because the mayor desires that people should live inside. And we don't do it without offering alternatives to their current living condition. In the best of circumstances, if a person is already matched to a housing resource, we will make sure that happens. In the worst of circumstances, when they've not been matched, we will offer a shelter bed. Our guarantee is that when we close an encampment, everybody in the encampment will have the opportunity to enter shelter. We can't make them go, but we can say we are not leaving you with no option as we close this site, and that's basically the way we operate. The last activity that I would like to discuss is our age-friendly DC work. Gail Kahn, is she a consultant status yet? Yeah, she's been trying to tell. We won't let her because she's very good. It's official when? She officially retired Monday, but we're going to keep her tethered to the office as a consultant. She's done a wonderful job with this very ambitious project. It's an initiative, as you know, to coordinate the community members and the public agencies to make the district a much easier place to live for persons like myself who are getting along in years. And so the goal is to, as residents grow older, to make this city a much more manageable and negotiable entity. There are a number of domains that are captured in their strategic plan that is a multi-sector plan, and I won't go through all of the domains. I'll simply say that the goal is to address issues related to the environment in which they live, housing, transportation, outdoor spaces, also impact attitudes about making sure that the community understands that there are issues that we need to address for people who are aging. We don't want them to live in isolation. We want to increase their community involvement. And we also want to make sure that they have a secure place to stay in the city. And that's both from a public safety standpoint and certainly from a financial standpoint. There's a progress timeline on slide 16 that outlines the things that will happen, that we anticipate will happen in 2025. I won't go into any detail except leave this for you all's perusal. And certainly if you have questions that either I or Gail can readily address. But suffice it to say, by the third quarter of this calendar year, they will be in the evaluation and report, the evaluation and assessment phase, and we will hopefully get some results on all the efforts that have been conducted under the banner of Age-Friendly DC since I've been in this role since 2017. So, lastly, I will turn your attention to Cedar Hill. This is the jewel of in our portfolio in terms of its potential impact. We will open April 15th, as the mayor announced. As Ben has been working aggressively and with great vigilance to make sure that all of the district partners are doing their job to ensure that the hospital will open on April 15th. Um, the hospital has obtained its conditional certificate of occupancy and fire and life and safety for the purposes of stocking and training. We can't take any patients yet. We have a ways to go, but we can get there. Between now and April 15th, we have over 20 approvals and milestones to complete. They include DC health inspections, federal CMS, which makes me a little nervous, and DA approvals. We have to finalize some hiring, and obviously SHPTA has to give the facility a license to operate. There are multiple agencies involved in this process. If you have questions, Ben can speak to all of them. My instructions to Ben remain. All I need you to let me know is we're on time and on budget. And so if something is happening that is preventing that, then he needs to deal with it and let me know if we need to bring city administrator and others involved to get it done. So right now we are on time and on budget. They've done a remarkable job in an era of hyperinflation. They've brought this project to virtual completion from a construction standpoint with a very, very de minimis inflationary impact. So I think that is, you know, a tremendous achievement. And, you know, I can't thank Ben and the folks at UHS and the team of the construction teams that have worked on this, Turner and MCM. They've done just a remarkable job. It's a beautiful facility, and I can't wait to see it open. And if I don't reverse my health conditions, I might be their first patient. But I will gladly go there if I have to. So those are the highlights that I would want to bring to your attention, and certainly yield to any questions you might have of me or my team. So with that, I return the mic to you.
Great. Thank you so much, Deputy Mayor. And as I mentioned, as colleagues join, we'll certainly turn to them as well. So I want to start on staffing for the office DMHHS. You noted in your pre-hearing responses that you all repurposed several vacant positions to meet the changing needs for the office, including creating an operations specialist position as well as a public affairs specialist position. What new needs emerged that necessitated those two positions?
I will let my chief of staff, who's so very capable, and I tell my team I always hire strong chiefs of staff, not just because I believe in it, because I do, but it also makes my job easier. And she is a strong chief of staff, and she handles all of the staffing and operations inside of the office.
If you can just introduce yourself for the record.
Sure. Kiana Creighton, Chief of Staff in DMHSS. So one of our current employees is on detail to another agency. But even before he was on detail, I was recognizing that typically a chief of staff will have either an operations specialist or a deputy chief of staff or an executive assistant. And we weren't operating with having that. And so there are a lot of operational needs, whether that's travel requests and approving for our agencies, actual time approval within the team and across the cluster, anything to do with our P card and pass system that is really difficult to be able to do in addition to managing the cluster. And so that would be the portfolio for that person. And then for the other one that you referenced, the public affairs specialist, I also had recognized that typically we had only operated with one comms person on the team. And the challenge about that is that some of the things actually came up during the public witness testimony last week that we're not able to do some of the cross-agency coordination, but also giving that information out to our CBOs and otherwise, because we're working with the agencies on standard operating procedures and communication, but not the pieces to actually connect that information outwards. And so this person would really be working in tandem with our communications director to be able to do more of that. And I believe I shared the actual position description. If not, I'm happy to send that over.
Right. Well, what vacant positions did you all cut or repurpose in order to do those?
So there was a policy advisor position. So we repurposed that one. And then there was actually a position previously to support Ben with Cedar Hill that because they have a team at DHCF, we didn't need that FTE within the deputy mayor's office. So we repurposed those vacancies into those positions.
Okay. in terms of, let's talk about a little bit of the cross-agency collaboration or not on some things. Deputy Mayor, in your presentation, you gave the highlights for all the various agencies in the cluster, but I know that you have lots of those agencies also have some serious challenges as well on a variety of different issues. And I'm curious in terms of your engagement with that. So let's first start with age friendly DC, which in theory should also be working with DACL on some of the issues that are arising there. How often do you meet with the DACL leadership, Deputy Mayor?
I have one-on-one meetings with the directors. We have a regular cadence where I meet monthly one-on-one with the directors. We go over issues of policy, programs, and personnel. The goal obviously is to have them raise to me any concerns that they believe I need to help them address. But I will say at the outset, you have to walk a fine line in a role as deputy mayor. If you're going to have competent directors, you can't run their agencies for them. You can't direct them to what they do. They work for the mayor, and I need to, and all the deputy mayors recognize that. So we don't, walk around giving instructions as to how they are to do their job. We say, look, you are employed by the mayor to do a certain job. Here are the things that the mayor expects to get done. Let me know if and how I can help. And if there are things that they're doing that are, run counter to the goals of the mayor or the executive office of the mayor, then we intervene. On issues of cross-agency projects, we often involve ourselves to make sure that the work is being done. But again, we cannot and we should not put ourselves in the position of trying to sort of execute the day-to-day for these directors.
I would agree with that. I don't think any director desires micromanagement in that way. However, there are some things for which it keeps coming up as a particular issue. And if that agency director is not addressing it, then I would turn to the deputy mayor to look to it. So for instance, one of the issues in terms of age-friendly DC, and this came up in the public witness testimony or DACL in general, is around the state of the wellness centers from a capital budget perspective. You've got wellness centers where there's only one sink in the bathroom that's working. But when I talk to the director of DACL, they say their capital budget is just fine. So if the capital budget is just fine, but you have an entire center where you only got one sink working, that tells me something is amiss. And recognizing that in those deputy mayor meetings in terms of the budget process, they might turn to you to advocate for some additional dollars so they can address some of these maintenance needs.
Yeah, when the budget development process starts, roughly in October, and it's an iterative process. We have multiple meetings with the agency directors. We go back to EOM. We let them know what the concerns are. If the agencies are making a request that they believe should be addressed, even in a stressed budget environment, we make that known. No director has raised a budget issue with me that I have not either examined to determine its validity or raised to the city administrator's office. I have not heard about any kind of insufficiency of capital budget at DACL, at least in my conversations with Director Hines, who's very good. We have not had any discussions about there being budget problems that would impinge on the operations of the wellness centers. But I will certainly revisit that. And sometimes you will get complaints in your public hearings that are not surfaced to me, at least. When I hear about them, my staff watches the public testimony. They take notes. And if there are things that particularly alarm me, then I will make sure that I have conversations with the directors about those issues. So sometimes you will hear things that I don't hear.
Okay. Well, so let's go a little bit further. You all this is DMHHS, not DACL. So
Right.
This is DMHHS released in its 2024 livability survey results this year. You surveyed about 611 community members to gather information on aging well in the community. However, when you take a deeper dive at who you all surveyed, 25% of the respondents were under 30. on a aging survey, and only 50% of them were under 60 years
Mhm.
old. So why wouldn't this particular survey focus on those of retirement or aging age?
Lee can come up, but I will say that one of the things that we try to do with age friendly is make sure that not just folks who are in a category where they would be considered aging, but also the larger community is made aware of issues that impact folks who are elderly. So
Right. But
as
this is
for,
a livability study, and you're
right,
asking, the quarter of your respondents were under the age of 30.
right. As for the specifics as to why the distribution of those who were surveyed lay out the way you described, I'll let Leah answer that question.
You would just introduce yourself.
Hello, council member. My name is Leah Behrens, and I've worked with Gail Cohn.
You gotta lean into the mic, hug it a little bit.
Hi, my name is Leah Behrens, and I've worked with Gail Cohn on the Age Friendly Initiative and specifically with the livability survey. And for our new strategic plan, the 2024 to 2028 strategic plan, that we took more of a life course approach. So the idea that if we have healthy children, those turn into healthy young adults turn into healthy older adults, so on and so on. We can't just start worrying about aging at 50 to 65. It's a very lifelong process. So we wanted to include more people of all ages in our livability survey. And the livability survey was open to 18 to 100. I think we had someone that was 101 that took it. So we very much wanted to understand how they see their process of aging and how they understand it and where they would like to see it going forward.
Okay. Why did you all choose not to disaggregate the data then by grade, race, age, or ward?
We can do that with further data analysis.
You can.
Yes.
Okay. I think that is kind of important. I mean, if you're using this livability study to inform a strategic plan, but if a majority of your responses are coming from individuals who are right, if you're under 30, you are experiencing this city very differently than someone who might have mobility challenges and is over the age of 55. And so if we're making decisions to say we need more bike lanes because those under 30 said this will help them live, but we're not really asking anybody over 50 how they feel about the situation, I feel like that's a miss. Let me ask about the strategic plan. So there were many objectives around things like housing, traffic safety that must be completed by other agencies outside of the DMHHS cluster. How are you working with those agencies to meet those goals? Were they consulted in the were they consulted in the formation of this strategic plan in terms of their ability to actually meet these objectives?
Yes, so we were able to take our past livability survey, that was the 2023, and that was looking and reflecting on the 2018 to 2023 strategic plan. We were able to look at what community members were saying and then take that information to our partners. And we have a community partner as well as a DC agency representative on our task force for each domain. And we were able to meet with each of those domains and collaborate before making the strategic plan.
Okay, so everybody is on board. So what tools do you all have to, I guess, encourage those agencies to meet their particular part of this? Because you can't be successful if DDOT's not doing their job.
Yes, exactly. So we're able to establish at the beginning some baseline measures, and we're checking in yearly as well. And we will have a progress report in fiscal year 2026.
Okay. I want to turn to the Interagency Council on Homelessness. In the responses, DMHHS reports that funding for a majority of the ICH staff is out of the DHS budget. It requires the annual execution of an MOU. Your response states that this creates significant delays in confirming funding available for hiring. So then I have to ask the question, why are these positions not within DMHHS? Like, why do y'all not just move the money as opposed to doing these annual MOU agreements?
So we actually had a conversation with OBPM about this a few weeks ago during our budget formulation meeting. We're going to work on transferring the FTEs to DMHSS.
Okay.
My understanding is that when it was initially done, it should have actually come to us. I think it was by error when the council graciously gave them additional people. They put it in DHS by accident. So that's why we have to do the MOU every year.
Okay, so hopefully when we see a budget in April, this will be rectified.
Ideally, yes.
Okay, great. In the ICH's July 2024 draft work plan, it proposed restructuring ICH to focus on healthcare, especially behavioral health. Um, is this happening after you all propose this, or? No. Oh, well, use your mic. Yes. They proposed restructuring ICH to focus on healthcare, especially behavioral health. Is this happening?
Yeah, go ahead.
So one of the concerns that Teresa, who's the executive director of the ICH, has talked about is that we're seeing a lot of intersections with people who are experiencing homelessness and
Yes.
their behavioral health needs.
Yes.
And so there wasn't a committee that was dedicated to that previously. And so the hope is that by having more of a focus on that, that they would be able to work more proactively with DBH regarding particularly around harm reduction, but we're also seeing that particularly older residents who are experiencing homelessness are having a lot of opioid-based issues. And so her idea with this restructuring is to be able to meet that idea that has come up previously.
Okay. My understanding is that there's a behavioral health working group, and the healthcare committee. What are those folks working on? Or is this the restructuring?
I believe that's the restructuring. I can double check with Teresa, who should be in the building now, to be able to speak to that more strategically. I know that the other piece here that she's been working on actually with DHCF is around specifically healthcare, and thinking about the inflow of information into HMIS and then thinking about the impact on residents. But I'll see if she's available to answer additional questions.
Okay. Is it possible for you all to provide the committee with a list of who are on these various committees?
Within the working groups?
Yeah, the
Yes,
working
we can
groups.
s-
Yep. And any meeting notes from the meetings that they've held thus far.
Yes, we can send those.
Thank
over.
you. The responses named several spending pressures for ICH, including not being able to compensate individuals with lived experiences for their participation on ICH, not being able to provide food at the meetings, and not being able to engage with residents currently experiencing homelessness. Did ICH have funding for these things in the past?
Oh. No,
No.
Because I would be,
But-
the food at the meeting, I know
No.
I've had other agencies who have had this
No.
issue, so I'm curious.
no, I don't recall them having funding for those issues. And I'm not sure why it would be listed as a spending pressure. But
Okay,
That's not intuitively obvious to me why they would call those items spending pressures.
okay. If the executive director is in the building, can she come down?
I'm trying to get her to.
Okay,
come.
great. We now have a lot of outside eyes on the district's work. And so calling something a spending pressure for which you never had a budget for in the first place is a problem, in my opinion.
Yeah, I was not aware that that was listed as a spending pressure.
All right. I want to turn to encampments. So my understanding is that in FY '24, DMHHS transferred about $444,000 to the Department of Human Services for outreach services for DC homeless residents. Why did you all transfer those fundings? Wow. Why did you all transfer that funding to DHS on top of what DHS already has budgeted for homeless outreach?
I suspect that it's a matter of need. We are, the outreach on encampments has been increasing precipitously. We need effective outreach if we're going to carry out the goal of moving as many people live inside as we can. So I surmise that an assessment was made that more dollars were needed on that front, and it was transferred to DHS as a result.
Okay, so DHS's budget for encampment specific outreach in FY '23 was 1.1 million.
Mhm.
In FY '24, DHS took that down to 908,000. So is this 444,000 intended to fill a hole?
I would have to check with the agency on that, because like I said, I don't have the details of their budget, but we certainly can check.
Okay. As you noted in your testimony, the number of encampment full closure and cleanups significantly increased in FY '24 to 36 locations. That's up from 13 in FY 2023. MPS similarly saw an increase as well. I think in FY23 they had maybe 3. In FY24 they went up to 10. What would you say is the reason for this increase? Is the majority of this health and safety related, or is something else happening?
Yeah, we, up until this year, there were no site closures that did not involve health and safety. We closed sites for health and safety reasons. Now, the regulations are clear. The mayor has the authority to indicate that there should be no encampments on public or private property. And so while we have used health and safety as the litmus test for whether or not we would close an encampment, we are now entering territory where we may close encampments for reasons that don't include health and safety. And they are more consistent with the mayor's goal that people not sleep outside.
Okay. So I just want to note for the record, so we haven't seen an increased number. We were at our peak in FY23. We had I believe over 100 encampment sites. And in
Okay.
FY24, there were 81. So we're doing more cleanups on less properties.
That's entirely possible.
Okay.
And easily explainable.
Well, let's break this down. Several of the encampment locations of the information that you all sent to us were directly outside of shelters, including an encampment outside of the New York Avenue Men's Shelter and one outside of CCNB. When your staff are speaking to these individuals, they clearly know that the shelter location exists and yet are choosing to be right outside of said shelter location. What's the disconnect here that's happening?
You asking me to articulate why?
No, I'm asking what your outreach staff.
Outreach staff does the same thing regardless of where the encampment is located. They will make it known that there are other housing resources, including shelter, that they should take advantage of. And if the encampment is a health and safety violation, then we will close it. So why an individual or group would set up an encampment outside of a shelter, I can't speak to that. But what we do when we assess that site is there a health and safety violation? And even if there is not, we make, through our outreach teams, make it known that we have shelter beds available.
Okay, but are we not? These two shelter locations in particular, if you've been there, they're old, they're dated. They haven't been renovated in
Which two are you talking about again?
CCNB,
Yeah, I've been there.
Second and D,
Yes,
and the New York Avenue Men's Shelter.
been there.
So, I mean, shouldn't that not entice us to do better in terms of our plans of rehabbing those facilities? Or perhaps they're in the timeline.
The New York Avenue shelter will close. The animal shelter will be located, partially will be located on that site. Others, we spend about $100 million annually on operating shelters. There are a number of shelter renovations that are currently underway. Are all the shelters that need repair being renovated at the same time? No, but we have, especially during hypothermia season, we have adequate shelter beds to accommodate anybody who's living on the street. And so when we close an area, when we close an encampment, or when we clean up an encampment, we remind the residents that you can go to a shelter bed. We can take you there if you desire. We cannot force them there.
I understand that.
But we make it known that that shelter beds exist for that purpose.
Yes, what I am saying is that if a person is choosing to live right outside of a shelter, that perhaps suggests something about the condition of the inside of that shelter.
I disagree. I disagree. You can't fully understand why somebody would choose to live outside, even if it's out in front of a shelter. That does not, in my mind, speak to an objective statement about the conditions in that shelter when we have almost 2,000 residents living in shelters now. Now, CCNV, that's an independently run operation. We're certainly hopeful that through the recent budget allocation, I think it was $60 million, that entire operation will be renovated and will become a better option for people who are living on the street.
What's the timeline for the closure of the Men's Avenue shelter on New York Avenue?
What's the timeline for that?
Councilmember, we'll have to check the exact timeline, but now that we have the new animal shelter in DC Village, I know that that was one of the pieces we were waiting to be able to close the New York Ave animal shelter to begin the construction process to move over to that location. On CCNV, I did just want to mention that we actively have been stalled in negotiations with the leadership of CCNV, which is a part of the delay. But I believe, I'll double check the date, but we're meeting with the leadership of CCNV in the next couple of weeks to be able to go through with both RICO and then DHS on what the requirements for the new shelter would be.
Mhm.
And then we'll have an updated timeline on how long those updates would take. But there's been a lot of back and forth between the DHS team and CCNV, which has been a part of the reason why the updates haven't happened yet.
How long have we been in conversations with CCNV? Because like CCNV has been, it's been a while.
I know it's been a
They
long
have, they have
time,
a
but
budget
it's-
allocation now.
They have a budget allocation, but I think what's unique about CCNV compared to our other shelters is that because Rico and the other people who live there also manage the shelter, it's a little bit different than a regular capital project. And so making sure that there's buy-in between them, there just has not been agreement. But I know that at least initial conversations around the updates predate even my time in the deputy mayor's office. But we can make sure to send you an update following the meeting that is scheduled with them.
Okay. I'm on the Human Services Committee now, so there's a lot of overlap on these two things. So in the FY23, we're still on encampments. In FY23, DMHHS reported that the district provides 1 month notice before the full cleanup closure of an encampment. But in this year's responses, you all have now said you provide 2 weeks notice. What was the reason for this change to go from 1 month to 2 weeks?
The 2 weeks is for the 2 weeks is for an immediate disposition. Let me get it right. So we have, if facilities is going to be cleaned up, we give, I thought it was a 2-week notice. If we're going to close a facility, we give it, what is it, 2-week notice? We're legally required to give a 2-week notice.
But we often give more than 2 weeks.
Yes.
Based off of what's actually in the statute, we have to give that amount of time.
Right.
But because the encampment team has relationships with people, they often try to give more leeway, which is why they move up the notice for a month or otherwise, but we're mandated to give the 14 days.
Okay, so in FY23, you all had a more flexible policy?
For cleanups?
In the
How did I-
documents that you all have written, this is what I'm saying, right? So a year ago, you said we provide 1 month notice before full cleanup closures. And then the documents you just sent us, you now say our policy is 2 weeks. I'm trying to understand.
We're legally required to give 2 weeks. We often give more than 2 weeks because of the nature of a closure. So it's very possible that if we're dealing with a large site, say McPherson, that we will, and we see there are 70 people living there. We will start posting signs that this site will close on date X, and that could be 30 days out. We're not legally required to give them 30 days, but we do so. Now, that is not a standard that we may adhere to in the future. It may be necessary for us, particularly if there are public health and safety issues, that we reduce the closure time. We may decide to close sites with 7 days notice if we see that there's a there are pressing health and safety issues. But we try to give the 30 days. The encampment team tries to give an adequate notice to allow people to, make plans. If they're not going to go into shelters, to make plans to relocate. And so we said, okay, if it's, if we don't see any urgent need to close the site within 14 days, then we'll give them more notice.
Okay.
Particularly if it's a large site. Now, if there are, if we see problems that create, especially safety issues, that timeframe will shrink appreciably.
Okay. I want to ask a follow-up to the pilot from 2 years ago now. I'm curious, are you all still tracking the individuals that were moved into housing?
Yes, we have data on all the persons that we contacted. DHS has that data, and we can collect that information. And whenever we desire to do another follow-up of what happened to the people who were successfully moved into housing during the pilot, we can collect that information.
Okay. We'd love to have an update.
Yeah, the last update we gave was a year ago.
Right.
And it was it showed that the program was a smashing success. I mean, we had a placement rate, I think, close to 100%. We closed 4 of the largest encampments in the city. And of the people that we placed, which was virtually 100% of those who were engaged, on follow-up, I think only one person was no longer in housing.
Okay. That was a year ago.
Yeah.
So I'm just curious
Yeah.
if we're able to maintain that. As we know from the testimony from before, right? A lot of these individuals have co-occurring
That's correct.
different types of issues, and housing is just one of the parts of it. If we're not addressing the other things, then they might not be able to successfully hold on to the
Yeah.
housing for which they were able to obtain.
We will update the pilot, the follow-up, and give you data from the last time that we followed up until now on where the residents are and under what conditions they are living.
Okay. In that regard, on something similar but different with regard to FY 2024, you all reported that there were 198 people who were living in encampments in the past fiscal year, 33 who were living in the encampments from NPS properties. I'm assuming that there's movement amongst them. So I'm taking the 194 and the 33 with a grain of salt. But let's say, so out of the 198 folks cleared by DMHHS, 73 completed a service prioritization assistance survey, but only 16 of those were housed. And then out of the 33 living in encampments cleared by NPS, 14 completed the SPDAT. And 2 of those individuals were housed. I'm curious, what were the reasons for the drop off in terms of individuals who filled out the survey, but only a smaller percentage of those individuals ended up getting housed?
There are multiple reasons.
Okay.
One of the things that we have to be cognizant of, and I'm reminded of this by the advocates who are sometimes opposed to us closing encampments. You cannot automatically assume that someone who is living in an encampment is higher up on in the priority order for housing than someone who's been in shelter for years, for example. So, and we have been told, and we listen and we learn. We've been told by ICH that it would be bad form to automatically reprioritize everybody who's living in encampments and put them in housing immediately. So a lot of times you see somebody fill out a SPDAT, they may fall lower down on the priority level based on, based on their responses on that SPDAT, compared to or relative to someone who's living in a shelter, may have been in the shelter for 5-6 years. So the specific reason for the drop off that you identify is I don't have the information in front of me, but I would just warn that we can't automatically assume that because a person is living in an encampment and fills out a SPDAT that they automatically go to the top of the priority order in terms of being selected into housing.
Great. I don't want to make that assumption either. I do feel like that was one of the risks of even the pilot, right? The idea that people felt like they had to camp outside in order to get housing. So we don't want to create that. It would just be nice to understand what the rest of the dispositions were. Because the only thing that you all said was how many people filled out the survey and how many folks who got housing. So if there are other things that happened with those individuals, we'd like to know. We've been joined by Councilmember Zachary Parker from Ward 5. He's on line. Councilmember Parker, If you're ready, give me an
I am
opportunity.
ready.
Great. It'll give me an opportunity to drink some water. So why don't you go ahead and do your round?
Okay, thank you. And it's good to see you, Deputy Mayor. I'm going to jump right in and try and continue on the same thread. And some of this may have already been covered. You were talking about encampment clearings. The number of encampment locations in the city has declined. What is the long-term strategy for expediting placement in housing, but also dealing with encampments popping up throughout the city?
The long-term goal remains the same, and that is to, you know, make sure that no one has to live on the street. Now, in terms of expediting strategies that will bring about their goal, as you know, the city is as you learn more when the budget is released, the city has a budget issue. Revenues are slowing somewhat and expenses are increasing. So we have to be cognizant of that as we approach any solutions to human service problems. What we are doing with encampments is we are basically taking the position that we want everybody who's living in an encampment to move inside. We're going to make a shelter bed available for any encampment that we close. And then we will work closely with DHS to see where that person is in the pecking order for housing. And if there are any impediments, if they have been matched to a housing resource or they have a voucher, what are the impediments to having that person receive housing? But the immediate goal is to try to get as many people as we can out of encampments and into shelter or into housing if they've been matched to a housing resource.
And what is our ability to do that in terms of capacity in our shelters and housing systems versus the people in encampments?
We have the capacity, especially during hypothermia season, we have the capacity to house anybody who's living in an encampment. I didn't check the numbers this morning, but they're typically running shelter beds over 200 available for any resident who's living in an encampment. So we believe we have the housing, the shelter beds available. Once hypothermia season ends, we'll have to take we have to do an assessment of how many people are still that we've identified who are still living in encampments, and do we need to add shelter beds to the current total number of beds to make sure that when we close an encampment, and we will be closing more of them, that we can say, look, you have a better option, and that's a shelter bed.
And this may be parsing words, but how are we defining encampment?
Well, it's any tent or structure that's on public or private property that people are using to live.
So is that just one tent, or does there have to be a certain number?
It can be multiple tents, but it can certainly be one. But we have found that sometimes one individual may have more than one tent.
Gotcha. So an individual tent accounts for an encampment, and
Tent
when we
tent or structure.
Or structure, and when
Yes.
we say the number has declined from about 105 in 2003 to 81, that doesn't necessarily mean there are 81 individuals, because as you're saying, someone may have multiple structures in different locations.
That's correct.
Okay, got it. One additional question here. What sort of public health, safety, or security hazards result when there is an immediate disposition or closure of an encampment site? I know often it is cited that these sites are removed because of safety concerns.
Yes.
But what are some of the hazards when they're actually being cleared, and what services are the city providing to individuals, but also to those responsible for clearing these sites?
Well, I can tell you based on past experience, the sites that I've visited that we have closed because of public health and safety, the number of hazards sort of run the gamut. There's bio waste. There's sometimes there's violence, people being harmed, being attacked. We see a significant problem with rodent infestation. We closed one site near a school because the person had a gun. So it runs the gamut. You know, when I visit
And I would imagine there's not a uniform way that you're clearing these sites because the threats may vary from site to site.
yeah, mostly it is uniform, except in the case where we find something like person has a gun, then we involve MPD, obviously. Um, but typically what happens is MPD will set up a perimeter around the sites that we're closing so that the encampment team is not disturbed by people who either object to what we're doing or support what we're doing. Once that perimeter is established, we work with other agencies to clear the structures after we have given the residents ample time to remove any belongings that they would like to keep, certainly any valuable papers. Then those structures are cleared, and we address any public safety hazards or public health hazards that we see. But again, that's pretty standard. We've closed encampments because people were throwing stuff over an overpass. You know, I think it was Thomas Circle, one of the circles.
Got it.
And there's a lot of issues with propane tanks, the use of propane tanks that creates significant problems for potential fire hazards. We see those things, we will close an encampment. So there are a number of reasons that qualify as public safety or health hazards that we we will respond to with the appropriate notice and close the encampment.
Got it. And then of the 81 encampments that you noted, how many of them are on MPS or federal land currently?
Yeah, we can send you the breakdown, but I can tell you of the closures, we closed 44 sites, 10 of them were MPS, 36 were district government.
And the reason why I'm asking that, obviously there's heightened concern, and as much as we can strategize with our federal and regional partners prioritizing federal and MPS land, I think that makes sense, just given the attention that they're likely to receive.
And let me say, we have a great working relationship with NPS. When they tell us they're going to close a site, they ask us to provide the social services, and we do. We go out and we engage, our outreach teams engage with the residents on that site. We tell them that MPS is closing this site on date certain, and they will have to leave because MPS will not allow them to stay. We, if they need a SPDAT, we have them fill out a SPDAT. If they have a voucher, we try to determine where they are in the housing process, and we make shelter beds available to those residents as well. So it's a great relationship that we've had with MPS, and we fully expect that to continue.
Awesome. I'm going to switch gears. The Health Benefit Exchange announced that in their oversight hearing 2 weeks ago that they finalized the benefit design for HIV care for 2026. And HIV treatments will have no copays, no coinsurance costs, no deductibles for residents, which is a big deal. How is your office assisting in the rollout of this?
They have a completely separate population that they focus on. We will provide whatever assistance they need, but they operate sort of independently of the Medicaid program with respect to those kinds of services. Our beneficiaries are not only exchanged for purposes of health insurance, we provide full coverage through Medicaid. But if they need us to help make that benefit known community-wide, we're certainly ready and able to do that.
And speaking of Medicaid, given the deliberations at the federal level about changes to Medicaid funding levels, what steps, if any, are you and your team taking to both educate residents about the impacts, but also ensuring there are sufficient contingencies within the Medicaid system?
I have an entire section of my briefing for the council member that deals with the impact of the proposals that are being floated about reducing the Medicaid match. And I can share with you in advance of that we have been working with all of the associations to let them know what the fiscal impact would be and how damaging those funding changes will be.
And when you say associations, what do you mean by that?
The DC, the Primary Care Association, the Hospital Association, there's a list of them actually, but
Got it.
We have Melissa Bird, who's not here today. My team has regular meetings with the associations to give them the data that we've generated, the estimates that we've calculated on what the federal match changes would mean for Medicaid in the district. And then we are working closely with them to not only make that information known to the staff of the congressional folks on the Hill, but also community advocates across the city to let them know that, you know, if these federal match proposals are implemented in whole or in part, the Medicaid program will fundamentally change.
And that change would be catastrophic. I would just say, and my time is up, if I too could receive that briefing or be invited to the briefing you plan to have with the chairperson, I would greatly appreciate
It's
it.
today.
The briefing will be in like 10 minutes. So sit tight. He's talking about his testimony for healthcare
Oh,
finance.
I thought there was some glossy closed doors briefing you're gonna get.
It's still glossy.
It's glossy, but we're all gonna get it. If you just want to sit tight for a minute.
Yes, yes.
Okay.
Thank you, Chairperson Henderson.
Thank you. Before I get to UMC, I do want to go back to ICH because I see that the director is here. So I want to re-ask the question. You know, the responses that were sent to the committee named several spending pressures within ICH, including not being able to compensate individuals with lived experiences for their participation on ICH, not being able to provide food at meetings, and not being able to engage with residents currently experiencing homelessness. I'm not aware that ICH had funding for these things in the past. And so I'm, you know, maybe terminology is important here. Spending pressure would suggest that we're over budget versus you don't have the funding for it to begin with. And so we're trying to get some clarification here. Okay, yeah. And just introduce yourself for the record.
Am I waiting for the button to turn?
No, you're
Okay,
on.
Perfect. Thank you. My name is Teresa Silla. I'm the Executive Director of the District's Interagency Council on Homelessness. And my apology for misunderstanding spending pressures. You are exactly right. Maybe those cannot be considered spending pressures, except for the lived experience stipends. We do have $20,000 for lived experience to reimburse the, I think it's the 4 or the 5 lived experience representatives that sit on the full council, and they are eligible for stipends of a maximum of $250 a month, $50 per meeting to attend up to 5 meetings. And the consistent response that we've gotten relative to lived experience, and especially as demonstrated by the People for Fairness Coalition's initiative to increase the number of people with lived experience at our table, they offered a similar stipend, but for people that are not ICH full council representatives, right? And they were able to bring, I think it was at one point up to 7 or 8 women with lived experience by offering them the stipend and introducing them to the Interagency Council on Homelessness. We were able to significantly increase the number of people with lived experience engaging with the ICH. And so this, to me, I think demonstrates that if we were actually reimbursing people with lived experience for their time, we would get participation across the ICH infrastructure.
Okay. All right. Thank you for that clarification.
Yes, and my apologies for misunderstanding.
No, it's
the
okay.
terms.
There are other programs that have spending pressure, so we're just trying to get some clarity here.
Sure.
All right, I want to end in sort of talking about Cedar Hill and United Medical Center. At the December roundtable, the committee hosted about the opening of Cedar Hill Regional Medical Center. You all testified that you'd be finalizing the mayor's appointments for the Cedar Hill board by the beginning of January. Have those appointments been finalized and made? I believe the mayor has 3 seats.
Well, I know she's made at least one. I'm on the board.
Okay, that's great for you.
Well, maybe. And I think she has 2 more to fill.
She does.
She has 2 more to fill.
Okay, My understanding is that the Cedar Hill Board has already been meeting.
Yes, we've had one meeting.
Okay, so we're down to positions of representation of DC folks, yes?
Yes, but we will have those resolved, in due time for, this substance meeting. The first meeting was kind of an organizing meeting. But, we will have the other appointments made.
Okay. Your testimony, you mentioned that Cedar Hill Urgent Care Center in Ward 8 has seen higher than expected number of patient volume. How is this affecting wait time at the urgent care center? And do we anticipate that the opening of the hospital will ease some of this? Although I don't know if somebody's at urgent care, we want them to go to an emergency room.
That's correct. I can't speak to the internal operations of the urgent care center, but my hope is that when the system is up and fully operating, that any issues around wait times would be effectively addressed. And I'm not sure there are excessive wait times at the Ward 8 urgent care facility. We can certainly inquire with the staff there to find out, but I don't have that data at this time.
Right. I mean, it's good to know that folks are going.
Yeah, absolutely.
And so, that's part of the process, but we certainly don't want folks to shift to an emergency room setting.
Yeah, and I do know based on anecdotal conversations with some of the staff, and Ben may have more information, sometimes the visits don't involve an urgent medical care need. It could be social services. There's a lot of that speaks to the depth of poverty. A lot of requests for clothes and food and vaccines, and so they're doing and they respond very affirmatively when they see those needs. But some of them are outside of the medical framework.
Yeah. I'm sure this will come up again during the budget process, but from the hat of the DMHHS, right? We get a lot of requests for folks talking about us needing a specific urgent care clinic that focuses specifically on behavioral health. And so I'm sure that's going to come up as well, right? Individuals who don't, I don't need a shot. I don't need a vaccine.
Correct.
I need to be able to talk to someone, and to help
Yes.
sort of deal with some of the other issues. You all testified that the freestanding emergency department in Ward 7 will have 14 beds. Is that standard for freestanding ED?
Good morning, Chairperson Henderson. My name is Ben Stutz. I'm the Director of Hospital and Health System Development. It's what UHS believes is appropriate for the population here. I can tell you in seeing others that they have implemented, they're anywhere from 10 to 30 beds.
Okay. What's the timeline for this project? Because if my memory is serving me correctly, there is an old school building that is on that land that needed to be cleared, that DGS, we've provided funding for them to be able to do so, but I don't believe that demolition has started.
So the contract for that project was awarded last fall, and abatement is first before demolition, but that is scheduled to start this spring.
Okay. You noted Deputy Mayor Turnage, and the mayor also announced to great fanfare about April 15th as the first date for patients at Cedar Hill. Will UMC continue to operate until that April 15th date?
Yes, they will continue to operate until the new hospital opens. After the new hospital opens, they won't be taking any patients. And there will probably be they will scale down through FIMS. There'll be a scaling down of the number of emergency patient deliveries to the hospital. And they will be working closely with UHS, GW in particular, to do an assessment of the existing patients and their needs, so that if they desire to be transferred to the new facility as opposed to another hospital in the city, the Cedar Hill will have a full picture of their health protocol and will be able to respond. The challenge will be those patients who are in UMC, but not for medical purposes. That's going to be a challenge.
Yes.
And we have.
just to clarify for folks, can you give, I don't,
Sure.
there's a lot of people in the public who are watching, so I don't want to give them, let
Sure.
them think about, let
The-
their imaginations run wild. So just be
Right.
clear.
What can happen in situations, and it happens all over the country, not just in DC.
Correct. And not just at UMC.
Not just at UMC. A patient will go to a hospital for a very, very legitimate reason. It can be a significant acute care issue. That issue is addressed, and then the time comes to discharge. The person needs to be discharged to a supportive environment, and that environment does not exist. And so the individual stays in the hospital, although they are not receiving any medical care, and the hospital is not billing for their services. There have been people in hospitals across the country and in DC that after they were treated have been there for a year.
Yeah.
And so there are a number of patients at UMC, I don't have the number in front of me, but it's double digits easily, who are not getting medical care and who need to be transitioned to a supportive environment.
Okay. And are you all, DMHHS along with HHS, sorry, DHS, and who else would be a part of that conversation?
So there's a weekly.
Housing Authority,
Council member, there's a weekly group now.
a
that
weekly group.
meets
Okay.
that includes all of the agencies you referenced, our housing agencies, DBH, and others who work to place these complex cases. We've placed between 10 and 15 people this past 3 months. And those were the hardest ones, but we continue to review the cases weekly as a team.
Okay. It would be, as a follow-up, Ben, if you can get us the number of how many people we're talking about.
I'll ask UMC for that information.
Okay, great. I am over my time, but I only have one more question related to the DMHHS portion of things. United Medical Center improvements did not have any capital spending in FY24, but in your pre-hear responses, you show that there's about 8.9 million in FY25 project costs in capital though.
No, that's not accurate.
So was that a typo?
I don't know if it was a typo, but it's wrong.
Okay. I was like, I don't know why we're spending 8.9 million
Yeah,
in capital.
in fact, there's a surplus in capital now, and you know, in complete transparency, they're trying to figure out if they can somehow convert that to operations, so it can be used to cover some of their closing costs as the hospital winds down.
Okay. One last thing, and note, we've been joined by Councilmember Wendell Felder from Ward 7. I just want to add a clarifying note. So before, when we were talking about encampments and shelters, and we just got to be very clear for folks. The New York Avenue Men's Shelter is not moving into the current animal shelter structure for folks. The animal shelter on New York Avenue has moved. The animal shelter at New York Avenue will be torn down, and there will be a new shelter for men built. So I don't want people to think that we are just moving folks into a structure that was built
That's
for
correct.
animals.
Yes.
I just feel like we need to be
No,
clear.
good clarification.
We all know that.
Right.
I just felt like we needed to be clear. Okay. Councilmember Parker, did you have more DMHHS related questions?
Nope, I'm ready to jump in to the glossy briefing.
Okay. Councilmember Felder, did you have DMHHS related questions? Okay. All right, go ahead.
Good morning. Thank you, Madam Chairperson, Deputy Mayor, members of your senior leadership team.
Morning.
I'll jump right into my questions. Deputy Mayor, given that you have purview of all the district's public health and human service agencies, is there a comprehensive plan that aligns the work of all these agencies to ensure that we achieve our overall public health goals?
Each agency has their own strategic plan to address the issues that they are responsible for in budget. There's not one document that sort of encapsulates all that every agency in the cluster does, but each agency has their own plan, and it is sort of our job and the city administrator's job to make sure those plans are executed.
What are the key measures being used to assess the overall quality of life for DC residents, and how are these measures being tracked and reported?
There are a litany of measures used primarily by the health department, looking at a range of population health issues. There's an exhaustive report that I'll make sure you get a copy of that lays out the items that they track and how those measures have changed over time.
You work very closely with my predecessor to ensure that the Ward 7 and 8 has a healthcare network. While we're excited about the Cedar Hill and the upcoming freestanding emergency room at Fletcher Johnson, what other plans do you have to continue to strengthen the healthcare network on the east of the river? And are there any major gaps that you're looking to close?
Yeah, that's a very good question. I think I think people underestimate how transformative this hospital will be, not just because it's a hospital, but because it's a hospital in an integrated care system run by, I think the largest or the second largest builder for inpatient beds in the country. That's UHS. And this hospital will be tethered to GW. And so you'll have a full range of integrated care services from primary care to urgent care to acute care to even the more significant and expensive care that goes beyond, that can only be handled by level 1 trauma centers. Those folks will have those options available to them as well. I think it's called quaternary care. And you have the urgent care center that's constructed there. If there's a gap, I think right now we are concerned that the growing demand for behavioral health services will outstrip what we have available through the hospitals and through the community centers. I know, and I can't speak about the specifics, but I know there are plans, private plans, to substantially enhance mental health services in the city. But those plans have not yet been approved, so I can't, speak in detail about them. But they are recognition of the fact that, the city has, as do most areas, they have a growing problem with behavioral health that is beyond what we are currently funding.
Thank you, Deputy Mayor. Continuing along the line of questioning as it relates to Cedar Hill, what efforts are in place to ensure that Ward 7 and 8 residents are ready to take advantage of any job opportunities that may become available?
There's been an extensive coordination effort between Cedar Hill and UMC. And Ben Stutz has sort of been on the front lines of the work that's being done, and I'll let him address what they've done and what's next.
Good morning. Thank you for your question, Councilmember. So Cedar Hill held its first 5 job fairs east of the river, 2 in Ward 7 and 3 in Ward 8, receiving 700 applications. The new hospital will also be subject to a first source agreement, which is being finalized with our Department of Employment Services. And overall, they expect that the majority of many of their positions to be DC residents. We are also tracking how many UMC staff apply to the new hospital. And of those who do, if they meet the qualifications, they receive a hiring preference.
We have several corridors in Ward 7 that are plagued with individuals with substance abuse. What is your overall strategy to get these individuals the support that they need?
That's a real challenge, and I can tell you why it's a challenge. When you have a congregation of persons who are struggling with drug addiction, and you respond, or the market responds with a treatment option, oftentimes, and this has certainly happened in Ward 8, the community grows concerned about the congregation of folks who are struggling with substance abuse and their need to be in and around the facility that's providing the services. So, our challenge is always to find a sufficient number of facilities or treatment options for persons who are who have drug addiction issues. But also, we have to be sensitive to, as best we can, to some of the community concerns that are raised about the location of these facilities. We have heard that on more than one occasion that there's a belief that too many of these facilities exist in Ward 8. Our challenge, of course, is when we look at the data, a lot of the drug addiction problems and behavioral health problems exist in concentrated areas across the city, and one of those concentrated areas is Ward 8. So we're trying to strike the balance of identifying the appropriate level of service and making sure that those services are arranged geographically in a way that does not burden the community that's not struggling with drug addiction. But that's a hard thing to do.
Thank you, Deputy Mayor. Mrs. Stutz would love to work with you and members of your team to maybe host a job fair in Ward 7 as we get closer to the opening of the hospital. Just more of a comment.
Thank you. I'll let the CEO know.
Got you. Deputy Mayor, a follow-up question to you. So I've noticed that on your website, that your website hasn't published any publications since 2017. What is the agency doing to disseminate information about the work that you guys are doing and any additional progress that you're making?
Well, when I are you talking DMHHS or DHCF?
DHHS.
Well, go ahead.
I want to make sure that you're looking at the right URL because most parts of our website are updated pretty regularly.
Okay,
So I don't know if you mean by publications, like a certain type of
like
report.
reports.
But the reports are only done based off of the aspects of the data that they're focusing on.
Okay.
So earlier we were talking about age-friendly DC, and we're moving towards a new aspect of a plan. So something like that is only done on a 4 or 5 year cadence. So there
Okay.
wouldn't be something in the interim.
Copy, which is a good segue to my next question. Since the implementation of the short-term family housing program, how many families have gone through the program and how are we tracking their progress now?
We'll have to get that data from DHS.
Okay.
They run their program specifically, but we will get that to you. We'll get that to you today.
All right. Just a couple more questions. Madam Chairwoman, I want you to get to the glossy part of things, so I want to respect your time. What steps are being taken to address the ongoing challenges at the women's shelter in Hill East?
Well, I need to know what are considered challenges in Hill East.
Conditions are deplorable. A lot of challenges in terms of individuals coming on the site, some domestic challenges. We can have an offline conversation in which I can brief you on that matter.
I'm more than happy to have that conversation. I certainly would like to engage DHS and ICH if they have information as well, so I can be more fully informed about what those specific challenges are and what we're doing about them. But we can certainly have that conversation.
Copy. What is the now moving along to the freestanding emergency room that's happening at Fletcher Johnson?
Mm-hmm.
What is the anticipated opening date of that center?
UHS anticipates opening that facility in 2027.
Do you anticipate any barriers to opening the center on time?
So that facility is a privately constructed and operated facility. The district's role is to create the infrastructure and do some of the remediation of the school that's on the site. There is a contract that's been awarded through DGS to begin that work. That work will begin this spring, and the pad site will be created for UHS by the end of this year.
Thank you. Thank you for all the work that you and members of your team do to improve healthcare outcomes across the district. Looking forward to working with you, Madam Chairperson.
Thank you, Councilmember Felder. Deputy Mayor Turnage, do you want to take a 5-minute break or do you want to go straight to?
I just got to run through the men's room right now.
Okay, great. All right. So we'll take a 5-minute break. And then when we come back, we'll do Department of Healthcare Finance.
Okay.
All right.
To the How are you? Yeah. Yeah.
You're not here tomorrow. If you are available, I can.
So, yeah, order.
Okay, we're back. And so we're going to move on to the Department of Healthcare Finance portion of this hearing. So Deputy Mayor Turnage, when you're ready.
Yes. At this time, Madam Chair, I would like to discuss the performance oversight of the Department of Healthcare Finance. The introductory slides begin on slide 3. Our operational goal for Medicaid and Alliance, it remains the same, and that is to make sure that the residents who are in those programs have access to high quality services to address their medical needs without respect to where they live, their gender, or their race. Joining me today are my experienced executive management team and our agency's exceptional fiscal officer. We also have our high performing administrators, some key managers, and other staff who might play a role in today's briefing. The focus of my remarks are a departure, as discussed on slide 4, from the normal practice at performance hearings. Rather than focus exclusively on the activities of the agency over the past 15 months, I would instead like to highlight the growing fiscal challenges around Medicaid, as well as the critical issues of concern related to potential changes to the district's federal match rate. We know that district revenue growth has slowed while expenses have not, especially for healthcare programs such as Medicaid and the Alliance. Further, because Medicaid is such a large component of the district's local fund budget, this confluence of circumstances puts the agency on a path for a day of reckoning, where critical decisions will be necessary to right-size the program's cost structure for the city. I want to turn to slide 6. We have been informed, that the Medicaid program and the Alliance, as we approach fiscal year 26, will need to be adjusted because we have cost pressures. And so if you have to adjust the Medicaid program in any significant way, you need to think about, I call it the 3-legged stool on which Medicaid sits. And that is, one is eligibility. We have done an outstanding job in the city since before I came here and through my tenure in really leveraging very favorable federal match rates to cover almost as many low-income district residents as federal law permits. And we have some of the highest eligibility rates in the country. We also fund a fairly robust set of benefits, allowing low-income residents to have access to, nearly the same array of benefits you would get from a commercial plan. Those, as a result of the scope of those benefits and the utilization levels in the city, our benefit portfolio is among the most expansive nationwide. And finally, the key to any system obviously is having an adequate number of high quality providers. And we have that in the city. So you have to have a reimbursement system that pays providers significant rates for treating people whose payer is the government. If you would turn to slide 7, what this shows is that if we don't make any changes to the district's Medicaid program design, the city will need to allocate $173.2 million in additional local funds to pay for the program in fiscal year 26. So if you take, and how did I get there? If you look at the Medicaid unadjusted budget for fiscal year 26, and that is what we describe as the amount of local funds that would be needed to fund the same eligibility levels and services that we paid for in fiscal 25, that cost is over $1.1 billion. Now, if you compare that to what we are projecting for the fiscal year end in 2025, that compares is somewhat higher than the $971,920,789 that we expect to spend in fiscal year 25 at its closure. And this increase in cost, this increase of $173.2 million, is primarily driven by enrollment and provider rate increases. And I would add that when you look at that kind of increase, and you figure, well, what does this mean if we cut $173 million out of the program? That is a local fund number, but we would lose the federal match for those numbers. And so we would have to reduce the overall Medicaid program by close to $600 million to adjust this spending pressure. That's local funds and federal funds. Now, what I would like to focus your attention on are the Medicaid cost drivers that we start talking about on slide 9. As you are aware that we had a period of decline during the pandemic in beneficiary enrollment trends. We went from, depending on the group, Medicaid in fiscal year 22 reached its highest number of total enrollees since I've been here. So 300,000 people were on the Medicaid program. That's our bottom row. That number increased slightly in 23. And then when by fiscal year 24, when we started recertification, because you remember from the time of the pandemic to some point in 24, we were not allowed to disenroll anybody from the program unless they came to us and said, I make too much money or I no longer live in the city. That didn't happen a lot. So the enrollment levels reached record highs. Once recertification started, you saw a decline in the number of enrollees total for the program, and also for each major category in the program. That's fee-for-service enrollees. They went from 58,000 to 48,000, and the MCO enrollees went from 246,000 to 220,000. That was from 23 to 24. Now that we have essentially gotten through recertification, we are seeing the numbers begin to go back up. There's a 7% increase in total fee-for-service enrollees projected for the end of fiscal year 25, based on the first quarter enrollment data. There's a 10% projected increase for managed care. And so overall, Medicaid is projected to grow by the end of the year by 9 percentage points. Now, when you think about the differences in the enrollment for fee-for-service and the managed care populations, it is important to remember how different these populations are with respect to their health profile and their cost to the system. Fee-for-service beneficiaries are only 20% of the people in the Medicaid program, but they are responsible for half of the costs. So in this chart, we use data that said we were spending $3.7 billion, and 20% of the members accounted for half of that cost. MCO enrollees, 80%, but they are much less expensive because they're younger and they don't have the utilization pattern that you see from an older fee-for-service population. On a per beneficiary basis, the differences are almost a factor of 5. It costs us $38,431 per member, per fee-for-service member, compared to just $8,438 for the MCOs. Now, if you go to slide 11, keeping those figures in mind, you will see that, as we mentioned earlier, the enrollment for fee-for-service, for the fee-for-service population has grown by 7%. Now, the reimbursement amount has grown by 2%. And you say, well, and this is despite the fact that if you look at the units of service for that population, the amount of care that they use, the per beneficiary utilization, and the per beneficiary cost, they've all declined. But because enrollments have increased and because this is such an expensive population, it's putting upward pressure on the total dollars that we have to spend on the fee-for-service population. And what's driving that? If you go to slide 12, two of the most high volume programs, certainly with respect to MHRIS, that is now a $360.9 million program. And that number has grown by 30% since fiscal year 2022. By comparison, the EPD waiver, which is also an expensive program, now costing about 165.7 million. That number has grown by 22%. And fee-for-service members dominate these two programs or these two service lines. If you go to slide 13, what's happening with the MCO population? The enrollment growth is greater than we see on the fee-for-service side. It's double digit. And because that enrollment growth is what it is, and we pay a monthly cap rate regardless of utilization. Well, if the cap rates factor in utilization, but if half of the MCO population decided they weren't going to get any medical care for the whole year, we would still pay that same cap rate because it's based on what the cost that we could expect the managed care companies to incur based on prior utilization. So the reimbursement amount for managed care has grown is projected to grow by double digits by the end of this fiscal year. That'll be 13%. On the per beneficiary cost side, there's a slight increase of about 3%. We think because of these challenges, and in the light of the current budget projections for fiscal year 26, at least what we're involved in now with this sort of iterative budget development process, it is unlikely that we're going to be able to get additional dollars to cover that 173.2 or whatever it was million. So we're going to have to find a way to propose reductions in the program to cover that spending pressure, unless, of course, there is a massive infusion of revenue through a revenue forecast or significant savings that we expect to accrue on other service lines, either in the Medicaid program or across the city. Those dollars will have to be, that pressure will have to be dealt with through reductions to the Medicaid program. And it's important that when we are dealing in an environment of spending pressures, we can't take on any new costs unless we reduce the cost for the amount of that enhancement that we're requesting going forward. That's kind of the rules those are kind of the rules that we have to play by. With that said, I want to shift gears a little bit to the Medicaid federal match rate concerns. We have been receiving regular reports from the Hill that Congress is considering proposals to reduce the Medicaid match rates, and to free up dollars for other funding priorities. On as slide 15 shows, on February 12th, the chairman for the Budget Committee and the House on Energy and Commerce established some specific reconciliation instructions for the relevant committees that unfortunately included an across-the-board reduction plan that would dramatically reduce the district's match rate, potentially as follows if it is enacted as law. They would reduce from 70% to 50% the federal match for the district's legacy program. And by legacy, I mean this was before expansion. So anything not involving expansion would drop from 70 to 50%. And then they would turn to expansion, which is also called colloquially Obamacare, and they would not eliminate the program from a statutory standpoint, but they would reduce the amount that the federal government would pay from 90% to 50%. And that is a pretty significant reduction, particularly for states who have indicated that if that federal match rate drops to 50%, which is even for states that have a 50% match rate on their legacy program, they have sent signals that they will not be able to go forward with Obamacare. And I should note, as we talk about these things today, this is a very fluid situation. Just yesterday, the House Budget Committee provided more details on a series of options that are designed to generate $2.1 trillion in Medicaid savings. That's $2.1 trillion over 10 years. Some of the most concerning options are to equalize Medicaid payments for able-bodied adults. That's Obamacare. They put a $690 billion tag on that. They want to limit provider taxes, which is what we have in a number of major provider groups. If the limits that are being discussed are imposed, it would hit the nursing home industry and it would hit our ICFs. Wouldn't touch the hospitals because we have their rate is rather conservative at 3%. Their provider tax is 3% of their revenue. Others are at the maximum 6%, and so they will get hit. They would consider lowering the FMAP floor, and I hope that doesn't mean what I think it means. When you calculate an FMAP, they base it on your per capita income. And so there's a formula that says, based on this per capita income, this person's match rate should be X. And if you are considered a very wealthy jurisdiction or state, that formula could kick back a match rate of 10, 15, 20%. So what Congress did was to make sure that people participated in the Medicaid program, they put a floor on that match rate of 50%. They won't go below their floor regardless of what your per capita income is. Now, if they lower that floor, you could have states, even a district. Because I think if you look at a pure match rate for the district and what it would generate in terms of based on our per capita income, we would be in double digits. It would be like 15, 20. I don't know the precise number, but I think it's less than 20%, which would be catastrophic, obviously. But they also listed in specific language, eliminate the special FMAP treatment for DC, and they put a tag on that of $8 billion over 10 years. So those numbers are sobering because of what they would do to the Medicaid program. And so what we tried to do, I did some back of the napkin calculations when this first came out, and then my team, as they always do when it comes to numbers, they clean me up. And so we tried to come up with a reasonable picture of what this would mean, what the Medicaid program would look like if the chairman's instructions to the House Congressional Budget Committees are eventually passed. If you go to slide 16, we see a potential Medicaid loss of total funds of $2.1 billion. Currently, we are forecasted to spend 5.2. If some of these changes go in effect, we would lose $1.1 billion in federal funds. And we have to assume, given that those dollars would not be replaced with local funds. So if you go to the next slide, you will see that projected end of this year, a $5.2 billion program. About $1.5 billion of that is a local match. If you go to what happens when these FMAP reductions are applied, the number drops to $3.1 billion. So essentially what you do is you take the 1.5 million local match, you give it a dollar for dollar match or a 50% match, and you end up with a $3.1 billion program. The last time the Medicaid program in total funds was only $3.1 billion was fiscal year 2017. Now, we are far from a situation of proposing changes to the program to reduce it to a $3.1 billion program for next year. Certainly, if the Congress acts with all due speed and the president signs any legislation that changes our FMAP rate in the ways that we've discussed, we would have to put together a major reconstruction of the Medicaid program. And on slide 18, this gives you just some sense of what would happen in terms of the funding, the groups that could be potentially affected, depending on the reduction strategy. The first row discusses the ACA expansion reduction in the city from 90 to 50%. That creates a funding gap of $373 million. The groups that would be most implicated by this reduction would be our childless adult population above 138% of federal poverty, and all of the Obamacare expansion group. The next row down shows what would happen if they reduce the legacy program from 70 to 50%. and that includes reducing the expansion group to 50%. The number is 830. I think if you use numbers based on fiscal year 2025 budget estimates, the number is 730. The number that I'm reporting is based on fiscal year 2024 actuals, I believe. Or I may have reversed that. Is that right? That's correct. So yeah, so the number I'm reporting is based on our actual spending in 2024. But if you use budget estimates in 25, that number drops by 100 million. But it is still catastrophic in terms of its effect. The childless adult population would have no funding, neither would the Obamacare expansion group, and some optional services, including services that for children, would have to be given a hard look. Now, if you do a reduction of FMAP across the entire program to $1.1 billion, then it is you have to basically attack every leg on that three-legged stool. You have to attack eligibility, you'll have to attack benefits, and you will have to attack provider rates. So I conclude by saying that I remind everybody that Medicaid is the largest insurance program in the United States. It's jointly funded, obviously, and is thus a major cost for state budgets. The district program is growing, perhaps unsustainably, during a period of slowing revenues. And if you're going to bring the Medicaid cost structure down, it's a complex challenge, and it will take some creative thinking, and at the end of the day, decisions that may not be avoidable. And what makes this so challenging is the Medicaid program serves, obviously, the most vulnerable populations in the city. These challenges that we now have, even without a reduction in Medicaid match, would obviously be greatly exacerbated if Congress implements these potentially ruinous reductions to the district's federal Medicaid match rate. But nonetheless, if this confluence of circumstances occurs, the district's program would require draconian cuts with some combination of eligibility policies, program benefit structure, and provider rate reductions. Madam Chair, that concludes my presentation. We did not talk about our activities, but we have, the relevant folks here that can address, some of the questions that you may have regarding some of the program activities that we executed over the last 15 months and, where we think those programs are headed.
Thank you, Director Turnage. Very sobering presentation of numbers that we've been looking at for several weeks. I just want to note we've been joined by Councilmember Brianna Doe from Ward 1. Councilmember Nadeau and Councilmember Parker, just so you know, with the order, it's myself, Councilmember Parker. Councilmember Felder left, so Councilmember Nadeau, you'll follow Councilmember Parker. That's okay. My questions are going to focus on what happened over the last year, because this is a performance hearing, not a budget hearing.
Sure.
And I think some of my questions lend itself to some of the financial pressure challenges that you all have raised, particularly as it pertains to the Medicaid program. So we're going to just jump right in. The 2023 external quality review of the Medicaid managed care organizations was published in April of 24. It found on average that most of our MCOs are meeting requirements. But I think the question I have here is, are these requirements set federally by CMS, or are they requirements that we set here locally?
There are requirements set they have requirements that are set federally, but we also have some expectations that we set and we monitor them on as well. I have and I wanted to share this with you before your scheduled oversight hearing with the plans. We do annual reports that are pretty exhaustive, and we look at the managed care companies across 5 different domains. I'll give you the latest copy that we have. One is in draft. I'll give you the draft copy. And we evaluate them based on those 5 domains, and we make changes to the programs based on what we see in that data.
Okay.
So I will get that report to you.
So those reports are separate from the external reviews?
Yes.
Okay. Just to forecast for folks who might be watching, the committee for the first time this year is going to hold oversight hearing specifically on the Medicaid managed care program. Partly because, as you mentioned in your testimony, it's over $1 billion that we are spending. And so we want to make sure that we're getting our money's worth. Okay, regarding the MCO NCQA accreditation status, AmeriHealth, UHC, and HSCSN should have all passed their next review date. What's the status of these accreditations?
Is Lisa here? We have our managed care manager here who is.
Oh,
well,
yeah,
she's-
I'm in the managed care section, so
She-
just come on up.
She runs our healthcare delivery operation, a big part of which is managed care, and she's involved in the day-to-day on.
Okay, if you could just introduce yourself for the record. No, it's not on. Just, there you go.
Good morning, Council.
You're gonna have to lean in. Or I don't know if you could pull it back towards you, but either way.
All right, how about that?
Yeah, all right.
All right, good morning. Lisa Truitt, I'm the Director of the Healthcare Delivery Management Administration at the Department of Healthcare Finance, and the Managed Care Program falls under that administration.
Okay. So I was asking a question about the accreditation status for AmeriHealth, UHC, and HSCSN.
I can speak to HSCSN and AmeriHealth. They're
Okay.
both accredited.
Okay. What about UHC?
My colleague Benjamin Abegbe, he oversees that program. That managed care contract is within our long-term care administration.
Okay. Don't go far.
Benjamin Abebe, Long-Term Care Administration, and that's affirmative. They're accredited.
They are accredited as well. Okay. All right. So AmeriHealth's current health plan rating is 3.5 out of 5 stars, whereas HSCSN is 3 out of 5 stars. Does Healthcare Finance have a baseline star rating that they require their plans to meet?
The star rating that we're working with is what's established by federal regulations. And so what we're working on is developing a report card so that can be published on our website, and then the legend associated with how those findings are determined would be associated with it. But right now we're aligned with whatever's in the requirements federally.
Okay. So 2 measures that district MCOs did not meet were all around network adequacy. One being adequate adult PCP urgent care appointment compliance and pediatric PCP urgent care appointment compliance. How does Healthcare Finance know how quickly enrollees receive urgent medical care?
So we have language in the contract that speaks to the appointment times that we're held accountable for making certain that we put in our managed care contracts.
Yeah.
One of the things that we do is work with our health plans to understand what their processes are. Are they going out into the provider community, into the provider offices to evaluate that? I will say that during the pandemic, as you know, everyone was home and there wasn't a lot of visits. There was a lot of virtual assessments.
Mhm.
And so health plans are building back up to that process. So I would say that it's very difficult to determine unless you have a person physically, as far as meeting those appointment timeframes. I'm sorry, because there's 2 different components to that, but the appointment timeframes. I do know that there have been some challenges with children because Children's Hospital is one of the largest provider of services.
Okay.
And one of the things we've recognized is that we have to better educate the families. They're dependent on the last time a visit was made. For instance, a well child visit, if they're tailoring it to the child's birthday, they're waiting until it's time. If it's not the birthday, they're also waiting until it's time for the start of school. And so they're getting everything done at that time. So there's an annual visit associated when they get it done. If it's the birthday, that's not bad as long as it's not associated with the return to school cycle. Providers feel or were under the belief that if they provide a service prior to within that annual time frame, they wouldn't be reimbursed. So there's an effort to educate the providers because they would be providing services within a 1-year period,
Right.
2 services within a 1-year period. So there's an effort to educate, to help them to understand that some of these visits can be parsed out. Some of them can be a little bit closer to the annual date, but we don't have to wait until the back to school period for there to be this rush for everyone to get the visit.
Yeah, because if you wait till back to school, you can't get an appointment.
Right.
Staying on the pediatric piece, dental network adequacy on Medicaid in particular has been well, first off, it's not one of the things that we measure, but I know anecdotally and from the amount of complaints that we get in our office, this is a huge, huge issue. A couple of weeks ago, I personally had to email the CEO of an MCO to get a family an appointment that they have been asking for weeks for dental. And so, how are we addressing the challenge of dental care network adequacy, whether it be for pediatric or for adults?
Let me say, there are significant rate issues with dental care. And we are looking at if those rate issues can be addressed in the current budget development process. We don't think we can fully address them
Well-
because they're significant. And I think and Angelique, correct me if I'm wrong, I think the rate issues that we have on the fee-for-service side are somewhat exacerbated by the rates that the MCOs pay. So it is a significant issue, but it has a financial link to it, and we have to figure out how to get there.
Understood. I would just note that, at least from our data, we have not updated the dental fee schedule since 2007.
Yeah, we
So I know a lot of dentists have said, we're no longer taking Medicaid patients because it is 2025 and you're still paying me 2 decades.
that is
ago.
precisely accurate. And we normally have a sort of an annual review of the fee schedule. It's not entirely clear how that could have happened. So we are proposing some changes, but unfortunately, the magnitude of what we might be able to do is now caught up in, a budget that will have some challenges.
I'd like to add to that too. One of the things since our last hearing, that we worked with our clinician office, our CMO office, they established a work group that works directly with dentists throughout the district. We even visited one of our dentists that provide care, and they raised their concerns. They raised some of the access issues that they feel are occurring because of the rates and other reasons, both on the fee-for-service side and on the MCO side. And so our CMO's office continues to have these meetings to make sure that we're addressing the immediate needs, even in a tight budget, because they're not all directly, rates are an issue as well. But there's some non-financial things that we can do to support our dentists in DC to increase the access. And
Well-
so we're working on that as well.
So let me ask you this, when is the last time that you all have done a census to determine how many dental providers in the district actually do accept Medicaid?
So that was a part of the analysis when the work group was determined. I can get back to you what the outcome of that analysis was.
Yes.
But that's how we determined who would be in the work group, what were the types of codes that we needed to focus on in accessing. And so our CMO's office, we can provide that information as follow-up.
That would be helpful to understand sort of the scope of the problem. Now, and I'm not picking on dental. I have the same issue on behavioral health where I've got psychologists, social workers, et cetera. They just don't accept Medicaid because of the reimbursement rates. And so, but then we have this pressure on the system. And dental, even though I don't understand why, before my time, before all of our times, the powers that be on the other side of Pennsylvania Avenue decided that dental and vision didn't need to be included in general health care. But here we are, especially knowing that, if you get a major infection from a dental, there was a kid who died in Montgomery County for an infection that was not treated, and we don't want that to happen here. I'm over my time, but I'm going to come back on the MCOs. Councilmember Parker?
Thank you. Is it possible for Councilmember Nadeau to go in front of me? I think she has to jump.
Sure. Councilmember Nadeau?
Thank you both. I appreciate that. Thank you, Chairman, and thank you, Director. Director, as you are aware, the Department of Healthcare Finance has decided not to submit the state plan amendment for Medicaid reimbursement of home visiting programs as required in my Home Visiting Reimbursement Act of 2023, which was funded in the FY25 budget after significant work from my office and the Health Committee. frankly, it's exasperating and I consider irresponsible that the Department of Healthcare Finance has made this decision despite the passage of the law, dedicated funding, and a history of council-directed changes to state plan amendments. Why is DHCF ignoring the law and refusing to submit the home visiting state plan amendment?
I don't agree with your characterization that we are being irresponsible. We are following the law based on the advice of two different attorney generals. Their advice is that when the council passes a bill that directs the mayor to change the state plan, that bill is legally insufficient. And that if the mayor agrees, she can direct us not to execute that SPA amendment. So in order to get a request to change the state plan to be considered on its merits, the language has to be constructed in a way that does not abrogate the mayor's authority as the executive officer and the sole person with the authority to modify the state plan.
Director, has the Department of Healthcare Finance submitted state plan amendments in the past as a result of laws passed by the council?
Yes, and we were told by the Attorney General that, and then we have also not submitted SPAs based on similar language, but we were told by the Attorney General's office that if we continue to enact state plan amendments based on language that is legally insufficient, that we run the risk, should that issue ever go to court, of weakening the executive's position that she is in this case, the sole person who has the authority to amend the state plan. And so based on that advice, we decided, as my job, to notify the mayor that this language does not meet the requirements of law. And we were told that we could stand down on the SPA amendment.
So it was okay to do it before, but it's not okay to do it now.
No, that's not what I said. What I said was, we have done it in the past, unaware of the fact that our agreeing to do it reduces potentially the mayor's authority to, as the sole person responsible for changing the state plan. Once we fully understand that, and we got the advice from a second attorney general, then I told my staff to make sure that whenever a bill is passed, we make sure the language is legally sufficient. And if it's not, then I need to notify the city administrator and the mayor that this is the bill that was passed. It is directing the mayor to do something that the council does not have the authority to do. And then she can decide whether or not she wants to go forward. But if you go forward, you potentially weaken your authority as the sole person responsible for amending the state plan in the district. And I would add, this is an authority that no other governor has. I mean, it's a valuable authority. And the mayor, rightfully in my mind, in my judgment, decided that she was going to protect that authority.
Yes, well, we're all very aware of the way she likes to protect her authority, regardless of what's at issue here. But as we heard in public,
I mean, she's the mayor of the city.
yes, she is.
Her job
And
is to
she
execute.
regularly flouts our,
and her
she
job is to execute.
regularly chooses not to implement the laws passed by the legislative body, which is the lawmaking body in the District of Columbia. As we heard in public.
I can only speak to this instance. I don't know what other issues you're referring to, but she responded in this way because I sent a notice to the city administrator and the policy director saying that this language is violative of the charter and the OAG has opined, and I recommended that we not go forward.
And why at this juncture, given how much dialogue this committee has had regarding this particular law, there was an extensive conversation in last year's budget hearing about the fiscal impact statement, the options to reduce the first year cost in order to get it funded. And this never came up until after we set the money aside for the program.
That's not an accurate statement. We've had this discussion before, and I have pointed out that this language is important to the mayor. And I assume it would not be important to the council because all it means is changing the language from shall to a may. But apparently it is important to the council. So I think the legitimate question is, why is that language important to the council when they can get a bill, any bill considered on its merits involving amending the state plan by simply saying the mayor may consider blah, 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 whatever the amendment is.
Well, frankly, I think that's ridiculous because what you're
Well,
effectively saying, please let me finish. What you're effectively saying is that because we are directing her instead of asking her, she's refusing to do it
No, that's
on
not what I'm saying.
principle.
What I'm saying is she's following the law. And she's following the law based on the advice of two separate
We make the
attorney
law.
general's office. Yeah, well,
We
then you
make
could,
the law.
well, then if you want that law changed, then you should do so.
Sir, as we heard in public testimony last week, the delay in implementation has put these critical programs at risk. Research shows supporting new mothers and mothers of young children has short and long-term impacts that help families providing a nurturing and healthy environment for their kids. And your own pre-hearing responses catalog the success of the Nurse Family Partnership, one of our home visiting programs here in the district. How are we going to expand this program if you're not going to move forward with the SPA?
Well, there are two issues there. You can get the bill considered on its merits by simply changing the language, and then the bill can be evaluated for its fiscal impact. And if the mayor agrees with both the substance of the bill and concludes that the fiscal impact is not onerous, then she will sign it. That's how you move forward.
Oh, I don't believe that for a minute.
Well, that's your prerogative. I'm just telling you how a bill moves forward in this case.
I am familiar with how
Now,
a
she
bill-
has the right to say that if the bill comes before her and the fiscal impact is something that she doesn't think the district can handle in this over the next 4 years of the operational plan, she has the right to say, I'm not going to sign it.
Well,
Then
we
you don't have-
funded that though. You're a couple steps behind. We funded the bill.
But you funded the bill, but my understanding is when you look at over the operational plan, there's additional costs. Now, it may well be those costs are sustainable, but you have to consider the fact that we're about to enter a fiscal year where the latest financial information shows that the citywide has only $40 million in surplus funds. That barely covers the spending surplus in DHCF now for the Alliance. That we just one agency in the city. So if you're going to say we're going to take on additional costs, I mean, it's very possible. It's possible to do, but then something has to be cut somewhere else. That's all I'm saying.
Oh, no, I mean, I disagree completely in the sense that we funded this based on the agency's estimates of what it would cost and that this will reduce costs because of the Medicaid match. Now, I understand that's at risk right now, but that is a separate conversation from what our policy should be, what laws have been passed, and whether or not this agency and the mayor are following the law.
I don't know how I can say any clearer that if the council would like this bill considered on its merits, they simply have to submit language that
We
is
don't want
legally
it
sufficient.
considered on its merits. We want it implemented because it's the law. I'm not going to change wording and then hope and pray that Mayor Bowser has a change of heart and decides to implement the SPA. That is why we put the shall.
That is your prerogative, and the mayor's prerogative is also if she chooses to not violate the law.
I don't have any further questions, Madam Chair.
Thank you. I'll follow up on this a little bit later. Councilmember Parker.
Thank you. Deputy Mayor, I wanted to come back to the Medicaid topic, and I know some of this is part conjecture because we don't know where our federal partners are going to land, and some of it is, well, all of it really is based on financials, which is not fully the focus of today's hearing. But I think we would be remiss not to just get ahead of this looming crisis. And I just want to summarize the headline. You're saying roughly, and I have your graphic here, that there's a roughly $175 million funding gap, in part because of rising costs. That if we don't make any adjustments, X number of residents will lose access to Medicaid. Along with that, we would lose out on matching funds from the federal government. Is that accurate?
No, yeah, what I'm saying is that if there are no adjustments to the a budget for fiscal 26 that's predicted based on what happened in fiscal year 25, the city has to come up with an additional $173 million in local funds to pay for that budget.
That's right.
Right.
And
if you don't,
the
you can,
compounded impact of that is that we would also lose out on matching funds,
yes,
that it would actually impact us around $600 million.
that is correct. If the city administrator and the mayor decided that they were going to not fund that increase and take it out of the Medicaid program, it would have a total funds effect of about close to $600 million. Now, I mean, they can fund that increase by cutting other agencies, but that is very difficult to do because, you know, DHCF and education are two largest agencies in the city, and it's very difficult to find $173 million in an agency other than the department, I mean, other than education or DHCF. So yeah, you're right. If they don't fund this by and they reduce that cost by cutting it through Medicaid, it's a total fund cost of close to $600 million.
And to be clear, how many residents would be impacted with that type of cut?
Well, it's difficult to say because it depends on how we came up with the 173 million local. I mean, if we reduced eligibility, yeah, we could easily determine how many people would be impacted. But you could also reduce benefits, or you could lower provider rates. None of those things are desirable, and they all will have negative consequences with respect to the current program. But either of those things will be necessary. One of the three, or some combination of the three, will be necessary to cut $173 million in local funds out of the next budget.
Okay. Is it possible for you to follow up with the committee with various scenarios? So it seems like you're discussing amongst your team different likelihoods to bridge that gap. And I would like to better understand what the possibilities are.
Well, we're discussing with the Office of Planning and Budget. We're giving them scenarios for adjusting this eliminating this 173 million. Those are working papers, and I can't share those until the mayor releases her budget.
Of course you can.
No, well,
of course you can.
If I did, then you'd be sitting over the appointment of another director. So I can't share those before.
Understood. Well, again, I'm not trying to get you in trouble, but I would like to understand the options available to us, and so I can follow up offline. And I also,
Sure.
I don't want to speak on behalf of the committee or for Chairperson Henderson, but I would imagine all of the committee that type of information could be helpful for.
Yeah, and I think, there is a slide in this presentation on slide 18 that sort of highlights some groups. It doesn't tell you the numbers, but it highlights some groups that would be affected by various cuts. Now, none of them are as low as 173, but it gives you some sense that, if we had to include eligibility reductions as a way to get to the 173, then, the population that might be affected, and you can look at slide 18 and get some sense of that. And like I said, if you want to have a conversation offline, I can certainly share with you sort of the mechanics of how, states typically approach these sort of things and how it could potentially be implemented here in the district, if in fact the mayor decides that she wants to move in that direction.
And then one more follow-up here, and then we're going to move on. So you're saying that, in effect, the funding level would be aligned with where we were in 2017.
Yeah, that's not for the 173. That's for the reduction in federal match.
If Congress were to reduce our reimbursement rate, but I'll follow up offline. I'm trying to wrap my mind around the impact and their converging crises that the district is facing, from layoffs to any number of fiscal cliffs, and now this crisis, that I do think we need to get ahead of it and be a bit more urgent. And I think it would do a great deal of disservice if we were to just wait for the mayor to reveal whatever the decision she's putting forth on
Well, let me
April 2nd?
say, there's a great deal of urgency around trying to prevent this from happening. There are, there are numerous meetings that we're having with staff to the Congress members who will be considering these potential reductions. We have also met with DCHA, DCPCA, the DCDD Coalition, and DHCA to encourage them, hopefully help them understand the magnitude of damage that would be done to the Medicaid program if these cuts are in fact executed, and then provide them with whatever information they need as they talk to people around trying to stop this. So we're very active in trying
And very quickly, how would you characterize those conversations so far?
I think people are kind of in shock and awe. When they see the numbers, they're like, oh my God. And they are fully aware of the damage this will do.
Okay.
I mean, I think they're stunned.
I do want to pivot to some other questions here. How does fee-for-services differ from managed care in terms of actual healthcare benefits?
There should be no difference. They have the same level of benefits available to them, except when managed care companies decide to provide benefits they don't charge us for. But in terms of primary care, urgent care, acute care, it's roughly the same level of benefits. If there's a difference, it's minor. And our policy director, who's sitting in for Melissa Berg, can speak to if there's a difference.
Yes, Eugene Sims, Policy Director, Department of Healthcare Finance. When we think about the Medicaid state plan, it's best to think about the Medicaid state plan and the services that are carved into managed care as a minimum. We require that our MCOs do not go below the level of care and services set forth in the state plan. But as the Deputy Mayor clarified, MCOs are able to add what's called value add services. Those are services that we don't necessarily build into the managed care capitation rates, but they choose to cover at no cost to the district.
Got you. A quick question. I think you spoke to this a bit. So are the fee-for-service beneficiaries also eligible for Medicare? And would Medicaid provide the same level of service, or not Medicaid, Medicare provide the same level of service?
I'm sorry, I missed the question. I'm sorry.
So are the fee-for-service beneficiaries also eligible for Medicare? And would they receive the same level of service?
Some fee-for-service beneficiaries are eligible for Medicare. They can be what we call dual eligibles. And we would pay for some of their Medicare, their co-pays, their premiums, and they would be eligible for Medicare, but they would retain eligibility for Medicaid services, especially long-term care, which are typically not covered by Medicare.
Okay. And then over half of the grievances filed, I believe 114 out of 202 during fiscal year 24 against HCF were due to application or recertification issues for medical benefits. What is the plan for streamlining Medicaid applications, recertifications for beneficiaries and bringing that number down?
You know, if you look at the recertification data, the latest numbers, and I can get April Keys up, who runs our data shop, it shows substantial progress in the speed at which we are processing applications. We are working every day to make sure that whatever flexibilities are available in DCAS that would expand the system's ability to cover things more efficiently, that we pursue those. But I think on average, I mean, you're going to have some grievances. That's just the nature of delivering healthcare. But if you consider that we are processing applications for over 300,000 or close to 300,000 people, and we have one of the lowest rates of, if you look at the recertifications, we have one of the highest re-enrollment rates of any state in the country. I think we're like 4th or 5th. I think we're doing a fairly good job in that area. So, but that doesn't change the fact if there are problems that we identify in DCAS that can be fixed, and we adopt the necessary changes and fix them.
Okay, I'm over my time for this one. Thank you.
Thank you, Councilmember Parker. I want to go back to talking about MCOs for a little bit. Again, there's a lot of what you do is dealing with the MCOs, so we need to spend some time with them. So I ended in the last round talking about dental network adequacy, and I want to go back to just sort of overall network adequacy and how you all determine whether or not an MCO's network is adequate
Mhm.
for the number of patients that have been assigned to them.
We have in the contractor ratio that the health plans have to adhere to. So a number of PCPs per a certain number of enrollees. Unfortunately, I don't remember off the top. I think it's like 150 for every 115 enrollee, 1,500 enrollees, one PCP. But I may be off on that number. And then for dental providers, we have, I believe it's for pediatric, 750 enrollees, a dentist for every 750 enrollees.
When's
But-
the last time that we've updated those
I was just
ratios?
about to say.
Okay.
But that is what we're looking at now specifically for pediatrics.
Okay.
Dental, because there is a distinction between the type of, you got it, the
Yeah.
type of dental providers. And so we are working on redefining that so it makes sense, because just recently when we asked the health plans to provide us with the number of providers, dental providers, speaking dental providers
Mhm.
associated with the child and adolescent population, there is a distinction in how they are entering that information in their systems. So a dentist may not be a periodontist or
Right.
a specialty dental provider, but providing general dentistry, sees children and adults. And so we haven't made that distinction clearly in the contract, but they are tracking it on their end, but we need to align. So we're speaking apples and apples.
Okay. I would love to know what our overall ratios are for all of the various pieces, because, one of the other questions I have is around ensuring network adequacy for pharmacists, for instance, where yes, for some of the larger chains, right, CVS, Walgreens, et cetera, they do accept Medicaid services, but we know that those types of pharmacy providers are not in all neighborhoods. And we want to make sure that folks can get access to their medications where they live or in the surrounding area of where they are. Speaking of pharmacists, we've heard that we've had some pharmacists that are gravely concerned about reimbursement rates, which are affecting their ability to stay afloat. Many of the independent pharmacies that existed in the district have already closed, especially east of the river. And so when we talk about evaluations of rates and otherwise, how are we having these conversations? Are they happening? Well, I know it's not happening on a time schedule because dental went from 2007 to now we still haven't addressed it. So I'm curious what's happening there. When I have the hearing with DC Health, they'll tell me, I think the chairs of all the boards have a meeting together. Are you attending that meeting, Director Turnage, with any regularity? Are you hearing from the chairs of these licensed providers who are telling you what the challenges are and with some of the reimbursement rates?
There are a number of pharmacy meetings that occur. We have pharmacists on our staff. They're now with the Office of the Chief Medical Officer. There's a Drug Utilization Review Board meeting. There is another one that I can't think of the name of it at this time, but the health plans participate, and pharmacists, the community participates in those meetings. And what you referenced about I guess the disparity between what's reimbursed on the fee-for-service side versus what's reimbursed by the managed care plans.
Yeah.
That is an ongoing conversation. As far as the pharmacies within the health plans networks,
Mhm.
all of the health plans have the district pharmacies within their network. We require them to have a specialty pharmacy within their network, at least one. And then they also have to be able to provide mail order delivery to their enrollees as well.
Right. Is at least one specialty pharmacy for the entire plan adequate?
I can say that I haven't received any complaints, so I can only go by what I'm aware of.
Okay.
But again, like I said, is we're looking at reevaluating the language that we have. It's under review. So we're recognizing that we do need to make some changes to be current with the climate that we're in today.
Mhm.
But I will say I have not received any complaints.
Okay.
There was a specialty pharmacy that was in the networks of the health plans at one point that was with all of the health plans. So as you're referencing, that could be a challenge when you're contracted with all of the health plans and providing services across those networks. There were some few exchanges with that pharmacy at one point, but everything seemed to have reconciled where it didn't turn into something that needed to be elevated or was having impact on access with beneficiaries.
The one thing that I worry, and I know you said like, oh, I haven't heard complaints, is that there are folks out there who don't know to complain, if that makes sense. The situation that I was talking about earlier, about the parent who was trying to get the appointment for the dentist, that was an ANC commissioner who knew, hey, let me involve the chair of the committee who might know someone who can help me with this, right? If that's happening to an ANC commissioner and she knows all of the people to talk to, I wonder about people who are like, I'm just grateful to have healthcare. I don't want to rattle things, but it's not serving me well. And how are we making sure that those, things are happening?
I think I was copied on, if it's the same one, I think I was copied on that communication. So I know what you're talking about.
Yeah.
So as far as the providers are concerned, there was a transmittal or communication that went out to the Medicaid dental provider community to make them aware of a process that we've implemented to give them easy access to send issues directly to DHCF.
Okay.
If they haven't been able to resolve it with the health plan. So the goal is you have the relationship with the health plan. Please work with them to resolve your issue. However, if you're unsuccessful, you're not getting a response, there's the ability for them to elevate it to DHCF. And when that elevation occurs, it is simultaneously received by the respective health plan as well. So they know that we're being notified.
Mhm.
And so then we're holding them accountable to resolve the matter.
Do you have that similar process for patients?
Not for enrollees. The health plans themselves have their own enrollee services lines. We require them to have that.
Mhm.
All of the enrollees receive an enrollee handbook. There's information in there about, and I know everything is dependent on somebody actually reading it, right? And so there are phone numbers, there's information for them to be able to access their respective health plan to submit complaints, issues, concerns, seek case management, whatever assistance they need to support it.
Right.
But it's all based upon the enrollee actually accessing and utilizing the information.
The more that we're sort of talking about this, interestingly enough, I feel like our MCOs are very similar to public charter schools, right? We are paying individuals to do this particular thing. They're semi-independent, quasi-independent. But if a family doesn't know the levers to pull, if you do have a complaint or something that is not being resolved by, in this case, the plan, where do you go, right? Do they know I could talk to healthcare finance? Do they know I'll file a complaint with DSB? Like, where do you go from there? And I don't know if we're being clear with enrollees around don't suffer in silence.
Right. What I've recognized is a lot of the enrollees will contact the ombudsman's office.
Yeah.
And they will get an immediate support from them. The ombudsman and her staff, they have a relationship with each of the managed care plans. And so they also work directly with them to get issues resolved as quickly as possible.
Okay. Does healthcare finance have any preliminary findings on the MCO performance in the behavioral health PIP?
Preliminary findings, if that would be in our ATR, we probably do. I just can't speak to it right now, but I can get back with you and let you know.
Okay. All right. I want to ask a sort of similar question. So you all have maternal health metrics for the MCOs. How are we working with them in FY24 for them to better adhere to it? And I just want to give some background. So 3 of the MCOs, AmeriGroup, AmeriHealth, and MedStar participate in the maternal health PIP with performance measures, timeliness of postpartum care, prenatal care, et cetera. In the 2024 report, the data showed that AmeriHealth and MedStar did not show any improvement. And actually, they were slightly worse in some of the metrics that you all raised. And AmeriGroup's was a proposal submission. So I'm not even sure if that was like based on actual. This data combined with the CMS report that showed that the district had one of the highest rates of severe maternal morbidity in 2021 is very concerning to me. If many of our births are happening on Medicaid, but then my MCOs are not meeting their metrics on the maternal health PIP, how are we improving overall?
Sure. I will say that the reality is all of the outreach occurs as is required of the health plans. They're trying to work collaboratively with some of the partners in the community, FQHCs, birthing centers, to be able to even know when one of their enrollees has delivered a child. What typically happens is they're looking at claims data because there's no, what can I say, there's no consequence if an enrollee is not reaching out to the health plan to get, because there are a lot of incentives offered to a pregnant mom when they notify the health plan. There are programs that they can participate in that will help them to hopefully have a successful birth. Prior to DHCF making doula services a covered services, that health plans were providing it as a value add benefit, another effort to try to get the enrollees engaged in their services. The HEDIS numbers is what is being referred to here. That's the healthcare effectiveness data and information set. That's what's used to evaluate health plans, and that's used for evaluation of the Medicaid health plans in DC nationally. And so I think those are the metrics that you're referring to, where it talks about the number of prenatal visits that should happen prior to delivery, and then the postpartum visit and all of that.
Right.
And so I will say that health plans do their best effort to connect with the enrollees, to incent them to participate and complete those visits. But, you know, some of the feedback is, this isn't my first pregnancy. And obviously there's no penalty applied to an enrollee for not complying. And, you know, we've engaged with the health plans to be very creative in what it is that they're doing.
Yep.
They offer and are required to offer new enrollee orientations when they do become, and then through those orientations, they try to educate about all of the services that are available within their respective programs. Also, when it comes to some of the maternal programs that they offer, they work, oh, go ahead.
So let me ask you this, because you're giving a lot in terms of what they are doing, and I'm sure they'll get into it in a couple of weeks, but are you all satisfied with the level of performance you're seeing?
No. Well, let me put it this way. We're satisfied that there is evidence of what we're requiring them to do is being done. As I mentioned earlier, we're returning back. Over the past couple of years, there's been a return back to the office where there was the ability for health plans to work directly from home, the staff to work directly from home. So as you know, case managers are doing a lot of the outreach to folks who meet the criteria to be enrolled in case management, and a case management program for maternal health is something that all of the health plans have. But I'm not satisfied with doing that 100% from home, right? When I was on the health plan side, there was a lot of knocking on the doors. I do understand we're in a different environment now, so probably there's some hesitancy in doing that. But some of the old tactics that worked before, we have to engage some of those now, just do it a little bit more strategically. But yeah, I would say doing what they're required to do, they're doing it, trying to go above and beyond by offering all of these other options to be able to engage and have the enrollee participate and really invest in their healthcare. I agree. I support it, but what I'm not seeing, a lot of those enrollees who are just absolutely not engaging, a little bit more creativity around that.
Okay. In FY24, the prior authorization timeframes for the MCOs changed across the board. And in most cases, these also got worse. Between the MCOs, in FY24, it took between 1 to 9 days for a non-urgent prior authorization. And it was up to 3 days for something that was declared urgent. Now, imagine, 3.5 days. So imagine having to wait 3.5 days to get authorization on something that your doctor has deemed as urgent. I think that this range is completely unacceptable. And it can be very devastating for beneficiaries who, you know, I'm waiting on a hip surgery or something like that, and I'm literally having to wait an additional week for my MCO to finally get back to my provider. Are we seeing any improvements in the prior authorization timelines?
So the report that we received was, excuse me, due in January, I believe it was January 31st.
Okay.
And so that report is being reviewed. But I will say, even prior to this, and again, there's not a perfect anything, right? And so I'm not saying that the health plans are doing no wrong. But what I am saying is that through the oversight, we're monitoring to make certain that they're doing the requirements within the scope of work. So when it comes to the prior authorizations, one of the things that we've documented and recognized is when additional information is needed from the provider, that is the holdup. If the health plan has all of the information that they need to make the immediate determination, it can be managed relatively quickly. But when there's the back and forth to get the information from the provider that's needed, that is what typically holds up the process. And I understand providers are busy, so it's all of these challenges that can create that little bit of a delay.
Has healthcare finance done any analysis on the impact of GLP-1 drugs on diabetes or cardiovascular costs?
I know that we have data from our actuaries, because that was something that was being considered. We do not cover weight loss drugs, but I think this Wegovy is the one that is, has a different indication where it can be used for cardiovascular disease, and there may be another condition. But we don't cover those at this point. We didn't get the approval. We do not cover those at this point. And so, but our actuaries did do some analysis for us to basically sharing what those costs would be like if it were a covered benefit.
For weight loss versus
For weight loss, if it were to
cardiovascular?
be considered for weight loss by our program.
Okay. I'm just, the headlines from other states, while useful, very expensive.
Yes.
And when we're talking about the overall growth and cost of the Medicaid program for some of the other states who have started to provide this as a benefit on weight loss, they have seen exponential costs.
I believe
Like-
that. Yes.
Yeah, it's about,
$1,000 for a,
it's 15, I was talking to our actuary yesterday. He said they're seeing costs of about $15,000 per person annually in some states.
in addition to everything else.
Yes.
All right. Okay. Provider onboarding and credentialing. So we've heard from some providers that they've been waiting months before credentialing process with the MCOs are finalized. Because MCOs are permitted 120 days from the receipt of all required documents to finalize credentialing. In your pre-hearing responses, you showed timelines ranging from 12 to 33 days. Why do we give them 120 days if they have been mainly accomplishing this in under 60?
That's a requirement. As you mentioned earlier, we require our health plans to be NCQA accredited. And through that accreditation, there are some standards that are outlined for health plans to adhere to. So 120 days is just the timeline for the completion. I don't know where that was founded from. I don't know if at some point there was some analysis done to get an understanding of the overall length of time, depending on not being able to collect all of the information that's needed to complete the credentialing process.
So how are we pushing them to sort of expedite? Because I could definitely see a situation where someone is like, well, I have 120 days to do it. So let
That's
me
not
not
what's
get
happening,
started
though.
till day 15.
Yeah, that's not what's happening. It goes comparable to the prior authorization. There is information that has to be received from the provider to complete that process. And if that information isn't provided, then it goes those longer time frames. It's my understanding that if everything is provided, or if the if everything is available to the health plans, they can complete it in about 3 days or even less than that. But it depends on what is provided to them. Even though information is given, is very specific about what you need to provide to us. There's licensure. Sometimes there's a situation where the license will expire in the next month. And then that's going to delay it a little bit because they can't credential them for the remaining number of days. They can, but they'll just end up going through the process again. So it's just the exchange of information.
Okay. We've heard from the Primary Care Association that they've investigated other onboarding models, like apparently Maryland does something very different that they say is much more efficient. Has healthcare finance considered other states' models to improve onboarding?
Yes, so the association has recommended that we implement centralized credentialing. And what that would do is eliminate a provider from having to try to contract with for the district 5 different health plans. So there's one location for that to happen. So we committed to have discussions internally and see what our options are. We know it can be done. We know that's something that's done by other states. We have pulled together a group of folks who would be applicable to just giving some context into being able to do that. We committed to giving a response to the groups, I think it was the Hospital Association, the DC Primary Care Association, and the Behavioral Health Association. We committed to giving them information around our internal discussions by the end of March, I think it is.
Okay.
But no guarantees that this is something we can do immediately, because it is going to take some time to put all of the processes in place in order to make it happen. And we're looking at using our contractor, provider data, PDMS, provider data, management system. They're the ones who are completing the applications when a provider is seeking to enroll as a Medicaid provider. They're doing this work in another state. So we're assessing, if they're doing it in another state, they should be able to do it at DHCF. It
Yep.
is going to have a cost associated with it.
Well, everything has a
And
cost.
some of the early but discussions with our external quality review organization, because they're familiar with it being done in other states where they also support that state. They're just letting us know that initially there will be some upfront costs that we would have to consider. But yeah, we are considering
Okay,
it.
well, we'll check in during budget around, because at that point you will have already shared your information with the associations. So we'll check in on that front. In terms of timelines for reimbursing providers, what does healthcare finances oversight and or audit look like there? And by that, I mean,
You mean for the MCOs, reimbursing providers?
yes.
Yeah, they have a timely filing requirement that they have to meet. In this report that I will give you, that's one of the things that we look at to make sure they're not gaming the system by delaying claims.
Mhm.
That it's a 90-day requirement, and if they don't file within that timely period, they can have a penalty that is an interest rate charge. We seen in the data that overwhelmingly they are paying those claims within the timely filing requirement.
Right. What I'm wondering is your system designed to have some sort of trigger alert if a claim is pending for a certain amount of time for someone on your staff to ask the MCO what's going on here?
We don't receive as you know, the provider bills the health plan themselves. What we receive from the health plans is a record of the paid claim referenced as an encounter or a
Mhm.
denied claim. The health plans have to pay clean claims within 90 days of
Mhm.
receipt. Within 30 days of receipt, I'm sorry, have to pay clean claims within that time frame. So if there are some issues with the claim, when it's denied, there is called a remittance advice that goes back to the provider
Yep.
to let them know that it's denied and the reason for. The provider just simply needs to address that reason, and then the process that the health plans have set up, then they would resubmit, and then they would be reimbursed appropriately if they've made that change.
Okay, we did have a provider last year for whom had some bills piling up, if you will, and never mentioned anything until it got too late. Now, in the analysis that you all did, it was determined that a lot of the claims that they were submitting were being denied because they were being submitted for uncovered purposes, et cetera. So what is the type of training or maybe reskilling or refresher that we're providing to providers around the appropriateness of submitting claims, et cetera? Are we doing that type of technical assistance on the provider side?
The health plans?
Yes.
Yes, they are. The health plans are required to have recurring trainings with the providers. One of the things we're looking at, so per health plan, you have a network of providers. You have to train them on whatever is appropriate that you're seeing in your relationship with those providers. And if submitting claims is an issue, and that is something that needs to be addressed across the provider network, we require them to do that training. One of the things we talked about is maybe having at least an annual collaborative activity where the health plans are working together to implement this training. So it's not these one-offs by the individual health plans.
Okay. It feels a little, and I know Ms. Truitt, you don't necessarily think this, but it feels like we have offloaded a lot of this onto the MCOs, right? We want you to do technical assistance. We want you to reach out to the enrollees. We want you to do the case management. We want you to handle complaints. We want you to do all of these different pieces.
Right.
And I feel like when we do that, in some ways now you are creating some entities that are too big to fail.
But that's really the scope of managed care. That is the responsibility of a managed care plan. The piece that you probably don't know about it, the Medicaid agency, as you're asking me, how do we do this and how do we monitor this? There are staff of folks who are responsible for oversight within those respective areas. And there are recurring conversations, there are reports that we receive from the health plans on a regular basis where we're trying to, as best we can, get as much information, because we're not there in their offices, but
Right.
get as much information as we can administratively. We discuss these reports with them if we see areas of deficiencies or opportunities for improvement. We're discussing those activities. We have now begun to work more collaboratively with our external quality review organization so that as we're putting, and also we have a new compliance person within our administration who's also making certain that that contract, as you've seen it, is what, 300 or so pages?
Yeah.
And everything that the health plan is supposed to do within that scope of work is not very neatly put into that contract, so that if I'm overseeing provider network management, there could be another section within that contract that specifies something that myself would be responsible for reviewing. So we're taking the time to make certain that we do have all of the right levers in place to hold health plans accountable. I think one of the things that we have to improve on, and that's our priority for this fiscal year, is the actions associated when we find those deficiencies or those opportunities for improvement. You know, how many times can you say that this needs to be corrected or this needs to be done this way? So when there aren't any consequences associated with it, is that back and forth. So that's another one of the initiatives that we're putting. Well, it's not an initiative, but it should be a part of the routine oversight.
Oh, wait, are you suggesting that at this point right now, there are no consequences?
There are, but we are more so working with them to resolve it. And I think at this point, we've done enough working to resolve.
Yeah.
Yeah. So now this is where we are. We have those options within the contract, so we're exercising those options.
Okay. All right. I want to shift to some questions about DCAS. Thank you, Ms. Truitt. So in the pre-hearing responses, healthcare finance, DHS and OSSI are entering into a limited data sharing agreement for the Sunbucks program. What's the status of this agreement, and do we anticipate it to be implemented in time for summer?
Hi, Tanika DeWitt, the Director of the DCAS Program Management Administration. It is the data sharing agreement is going through the process now. We do anticipate that we will have it signed by the agencies before the next round of Sunbucks, but we also have a process that if we do not have this implemented and we cannot share that particular data set, that we can share the SNAP data as we did last year when we implemented the Sunbucks program.
Okay. All right. So, y'all know how I feel about DCAS and how much you love it. We've spent so much money on this program, and I still feel like on the DHS side, that staff is having a real difficulty with the program in terms of some of the functions that they have to do around applications and otherwise. And I mean, some of that is a DHS issue, but I'll focus on the stuff that you guys can control. So hang on one second. I'm trying to. All right. So these questions I have are sort of follow up from the DCAS roundtable that we did last year. So during the July roundtable, I asked how many applications were pending but had not been opened in the system. So like it's been submitted, it's pending, but nobody had actually clicked to like open it yet, versus they were opened, but it was determined that it was too complex for immediate resolution, et cetera. And then in the post roundtable data, it showed that there were over 1,000 Medicaid applications that had been pending in DCAS where it hadn't been opened yet. And so how frequently are we revisiting this data to determine whether or not we're making progress here? And yeah.
Okay.
I guess the second part of that question would be how often you all are looking at the data of the number of applications that are currently opened and or pending over at DHS.
So I take that to mean that applications have been submitted through District Direct, and it is ready for processing, but it is over the allotted time frame.
Yeah.
Order process. So we have our process where we do keep those open, if so that if a person they do not lose coverage if they have eligibility. So we do have that for recertifications. For applications, we send DHS a report. We send that, either that report goes out daily, I believe, in which we have all the applications that are ready to be processed. So that's a part of our process that we do, is that we make sure that DHS understands and they knows all applications that basically are ready to be processed, which means their verifications have been provided, because we check the other systems to ensure either it's in DCAS or it's inside DIMS or another system, and that a caseworker can pick that up and process that case. That's as far as we can go on our side of facilitating support in that area.
Okay. We heard concerns from some public witnesses who testified last week that beneficiaries who don't have social security numbers face challenges easily checking the status of their application. Has the DCAS team determined or discussed rather assigning some sort of personal reference number so that folks can easily get that if they don't have the other number
Yes.
available?
So everyone is provided a personal reference number. The issue becomes if the person has multiple. And so a lot of the time.
Oh, wait, hold on. So every time I submit an application, it's a new number?
No, what I'm saying
Okay.
is that if a person has maybe a prospect or they've submitted other applications in the past, what usually happens is the system has to check that. Per our HIPAA, regulations and security, we have to actually check and make sure that this person is the same person, and we have to match that record up. In order to do so, the system has to collect all the data and present it to a caseworker, and they have to actually either merge the case. That usually happens when people do not have more than one PRN. We have to then take that in, basically consolidate it into one. We are looking into other ways. We have an entity resolution that we are working on, a tool that we're working with DHS on in order to more simplify that process and make it easier for the customer, because we understand, for the resident, because we understand that that can be difficult on their side,
Mhm.
because they have to call into our call center and then we have to provide them with, additional information. So we have some tools and technology that we are using to make that process easier for them in the future.
Okay. And I know I've brought this up before, but maybe it would have been with healthcare finance, but definitely with DC Health, the desire to have some sort of tracker, much like a pizza tracker, right? At Domino's, I know when it went in the oven and when it came out on the other side. I don't understand why on all of our application systems, we don't have some sort of tracker so people kind of know where they are in the process, as opposed to thinking that they've submitted something into a black hole.
Mhm. So we have the ability to provide that. We have offered it. It is, and it was requested that we do not put that in place at this time from DHS, because they do not have a similar process at their service centers to do that, to do ticketing. And I guess the response that would happen if we were to do something like that, it would not be easy on their operations. So we were requested, because remember, I don't have independent governance over what we necessarily always put into the system. So
Okay.
therefore, when it was suggested,
Now I'm going to ask DHS this, because I know
Yes.
they're going to say, oh, our service centers can't do it. But what I suspect DHS doesn't want folks to know is how long their applications are actually pending for. Because
Well-
you put in a pizza tracker, then I know, right? We are well on SNAP applications, which I know is not healthcare finance, but nonetheless, it's part of the DCAS system. We're not meeting that 30-day time threshold that the federal government has outlaid. We're not meeting it. They blow past it every time. And so I feel like it's fine. I'll ask DHS on that front. I don't want you to have to sort of guess on that. In that regard, sort of with the relationship with DHS, we discussed the district's poor CAPER percentage. So that's the case and procedural error rates, which is a joint issue between the both of you. However, our witnesses shared their experiences where language access has meant that some folks could not complete the application. What are we doing to improve language access on the platform?
Are we saying that they were unable? So our district directors translated in the languages, I believe right now is Spanish, Amharic, that we have it translated. And if if those languages are not available, of course, we have the language line services that are available.
I was glad to see that we've improved our processing of newborn applications within the 10-day period. Did we determine what the operational inefficiencies were that led to that being a challenge?
No, that's a DHS process. I'm not sure. But yeah, but they are processing them. I think 85% within the first 2 days, and then by a week they have not had any go over since June 2024.
Okay. We discussed during follow-up of the DCAS roundtable that healthcare finance was doing a data reconciliation, particularly around working with MCOs to update beneficiaries' addresses. What's the status of this? I think the last time I had asked, like, how many pieces of return mail, I think I asked Eugene that, like, how many pieces of return mail were we seeing during the redetermination process? And so, how are we resolving some of this?
I do just want to say a thing about the newborn process. We had an interagency work group with our MCOs, these DHCF staff and DHS staff. I think there was a lot of education that was needed. And I think that's why we're seeing some of the improvement in the deemed newborn processing, because we did work together to address that. Can you repeat your question on the return mail processing?
So my understanding is that you guys were going to be working with MCOs to update beneficiaries' addresses because, you know, we get the however many pieces of return mail that you get. So I was just wondering what's the status of that project?
I believe we are at least a few data files in. I think that process started up again late last year. I could confirm and get back to you, but I believe we're at least a few months into that process.
Okay.
We
How
started.
much return mail are we seeing these days?
We see it's a lot of mail. I think return mail, the last number I have, I think it's fairly consistent, around 1,000 pieces a week return mail.
Mm-hmm.
I think that number is fairly consistent.
Okay.
And I can confirm with our DHS colleagues and get back to you with a more precise number.
I'm gonna ask a follow-up on the mail piece when I ask about fraud, but I want to just finish up on some of the questions around DCAS. So one of the things that we discussed last year was around workforce system upgrades. So to reduce clicks for the workflows of how many moves that a DHS employee had to make in order to do a particular thing. I don't know, update a file, change an address, X, Y, Z. And you all shared in July that this upgrade was scheduled for later in July. Did that upgrade happen?
It did.
Okay. I understand that the version 8 Curum upgrade occurred in July as well.
That's the upgrade.
No, that is the upgrade for that. Okay. Have we heard any feedback since the upgrade?
It's still, feedback is still that there's too many clicks.
Okay.
I think that part of this is conversations with DHS and understanding the perception of the clicks, and also just understanding that, we have an integrated eligibility system that is driven by policy from multiple programs. We have about 85 programs that is within DCAS. And so in order to provide the residents with getting straight through processing as much as we possibly can, and gathering as much information as we can up front from the residents, it does require what I would say, a number of clicks so that we can gather the amount of information that we need.
Mm-hmm.
Now, what we are working on is determining if there's more efficient ways in which it will be perceived from the caseworkers that are processing it. I think that that's part of the issue as well. So we're working on it. We're talking together. We have Meredith, who is our product owner. I actually had a meeting with them yesterday to talk some of that through, to see how other states are also experiencing this, and we are on par with the number of, like, I don't even like the terms in terms of clicks, but the amount of information that must be collected. And so we are just looking at other models to determine what better way we can structure the system so that it's easier on the caseworkers.
Okay. I want to talk a little bit about Medicaid fraud, but also in terms of how a beneficiary might alert healthcare finance of like, I've either moved, I have my own healthcare, or something else. We had a constituent who emailed us. Her son has been gone, and yet she keeps getting letters saying, here's your healthcare card for Medicaid for her son, who she said she's reported it several times that they are no longer in the district. And yet it seems that that young man is still enrolled. We are still paying taxpayer dollars for this individual at a managed care organization. And so can someone, through district direct, can I say, hey, I'm no longer interested in Medicaid?
All right, we're gonna have to switch out.
Yeah.
Yes, you can report life events within District Direct.
Okay. Do we track how many people do that?
How many people report life events? Yes, because they have to be, the system has to update and they have to be processed. So yes.
Okay. What if somebody though is a family member who is not access to the district direct portal?
Oh, no, so are you saying if someone were to, you can't do that on someone else's behalf because you have to have access to the account in order to report a life event. So you can call a service center, you could call one of our call centers and do it that way, but you wouldn't be able to, unless you're an authorized representative, you wouldn't be able to go into, to report it on District Direct. if it's
Okay,
not
but
your-
you would have to either call or appear at a service center and then provide some sort of documentation to suggest that you can make this move on behalf of
I
someone?
assume it depends on what life event. Yeah. Yes, if they're inside of the case, yes. Sorry, what Eugene is saying is just that if a household member, a household representative inside of the household, they can go ahead and change that information within District Direct.
Okay. This case was pretty unique. I guess I'm trying to understand in terms of like, how when you have a license and you move, that people don't always go to the DMV immediately, right? There are folks in the district who are still holding on to their New Jersey driver's license, even though they've been here for a minute. But since their New Jersey driver's license doesn't expire until 2027, they continue on. And what I'm trying to determine is, are there triggers in our system who can catch if Bobby left the district 2 years ago, Bobby doesn't live here, but would have been a passive renewal for us, right? Are there any information that would tell us, oh, wait, hold on, Bobby is getting healthcare in New Jersey, so we should no longer be paying for Bobby here in the District of Columbia?
So
or do we have to wait for Bobby to alert himself?
So I'll go ahead and get past the colleague because there's not a process per se like that in DCAS, but there's a pairs match that we do that would alert to that.
Okay. See, everybody got to stay alert. You never know. We're going to go to the table.
Good afternoon. I'm Kevin O'Donnell. I'm the Director of the Division of Program Integrity.
Okay.
And in our division, we have the Paris match, as Tamika mentioned, which is the Public Assistance Reporting Information System. That is a centralized database where all of the states, on at least an annual basis, we do it on a biannual basis, send to a centralized federal database all of their enrollment data for SNAP, TANF, and Medicaid. And then we get a report back that cross-references Medicaid enrollees, SNAP and TANF enrollees enrolled in the district who are also enrolled in those programs in other states. And then we have a process whereby we send requests for information to all known addresses for those individuals and then notices of termination, such that if somebody's enrolled in New Jersey and they show up on the Paris match, we will send them a letter, ask them to confirm whether or not they're living in the district and still eligible for benefits. And then if we don't hear back or if they confirm that they're not in the district, then we can terminate them at that point.
Okay, when we ask for them to confirm whether or not they live in the district, what type of documentation do we require?
Sort of the standard documentation that you would expect for these sorts of things, utility bills, mailings, driver's license, things like that. We have a list. I'd have to double check. I could send you a copy of the request for information template that we use that lists the acceptable documentation that they can provide.
Okay, approximately how many people in the last year popped on this list?
So it fluctuates, and there was a transition for a number of years. The Department of Defense ran Manpower, which was the centralized database, and it switched just last September to the Department of Treasury. So the numbers can be different depending upon a variety of factors. I would say when we deduplicate the numbers that come in, we're typically coming up with anywhere from say 15 to 20,000 names that will show up on the list.
Okay, 15 to 20,000 that show up on the list, then you go through the process.
Yeah.
And then of that, how many people
How many people
are not district residents any longer?
So just this last year, we automated the process. It used to be sort of an incredibly intensive man-hour effort to send out these notices where we're sending them out one at a time. Just within the last roughly year, we've automated the process to where we shoot for about 4,000 RFIs to go out every 2 months. Again, the numbers sort of fluctuate, but I would say on average, what we've seen is, as an estimate, maybe 90% of the RFIs that we send out will result in a termination at the end of the month following the issuance of the RFI.
Okay. Now, how much do we pay again per person in MCO? 8,400. All right. I was saying we looking for money. If we are paying an MCO, because imagine when we terminate, the MCO doesn't give us that money back for the remainder of the year.
So the capitation payments, as I understand it, this is not my particular area, but it goes out on the first of the month of each month. So the month following the termination, those capitation payments will stop.
Okay, so we do get some money back.
Yep.
Okay, that's good to know.
Well, not back, but we avoid the cost. Essentially,
Yeah.
it's a cost avoid.
They're not there on the rolls, we won't pay for them.
I'm sorry?
If they're not on the Medicaid rolls, we won't pay for them.
No, I know, but my question is how long it took us to determine that Bobby was a New Jerseyan,
Right.
that MCO had been receiving money with no claims for Bobby because
Right.
Bobby is in New Jersey. We're not getting that money back.
I mean, we could press the issue, if it were a substantial problem, we could certainly press the issue. But, we think the system of identifying, at least for Medicaid, is pretty efficient, especially for folks who don't report income. We have a direct feed to a federal data hub that tells us what a person's income is. We can terminate based on, higher income. We'll send them a notice. You seem to be making a lot more money than you reported. So if you don't clarify this in a certain time period, we're going to terminate you. I think it's as efficient as it can be without ending up committing errors that throw people off who shouldn't be thrown off. That's the last thing we want to do. But we certainly want it. In ways that if there are areas that we can make more efficient, we certainly are open to, examining those. But the Paris process has been improved tremendously. I think it's very helpful.
Okay, but this process doesn't exist for Alliance.
No.
So how do we do that on the Alliance side?
Well,
Or how do we do what he just described? I'm sorry, his last name again?
O'Donnell.
What Mr. O'Donnell just described of like, you have this automated system where we're pulling data down from the feds. We don't have that in the Alliance program. So how do we verify that someone who is a beneficiary
it's
is?
a lot more difficult, cumbersome, and less effective, to be honest. Because we don't have a way to, as you know, we don't have a single identifier that we can track them across state. So it is, and generally we will focus on when the issue comes up sort of on special circumstances. Like, for example, we were doing some work on the number of people who came on board through Alliance beyond our projections after the bus transport started. And our initial analysis showed that, 90-some% of them or more than that didn't have addresses that were familiar to a residence. So we started the process of first contacting the organizations that whose addresses they were using, and then we asked for updated addresses. But we dug deeper into how they determined how they proved eligibility, and for the most part, they all had DC-1 cards.
Okay. When was DC-1 card added as a form of ID?
I don't remember the specific date, but it's on the website as it's sort of a piece of ID that trumps all. If you have a DC-1 card, you can get Alliance benefits.
Okay. How often do we audit on both sides? Medicaid and Alliance?
Well, Medicaid is ongoing because we have the data to, determine whether or not somebody is eligible. We have the systems and processes. Alliance is a bit more difficult.
When's the last time we audited Alliance program?
When you say audit, how do you just going in and checking?
Yeah. So, I mean, we asked data of how many people on both Medicaid and Alliance who have never submitted a claim. Now, people could be very healthy, and that's great for them.
Correct.
But to not have ever gone to a pharmacy, an urgent care, a doctor.
It's probably more common than you realize. And
In 3 years?
well, we often look at how long we look at, utilization data to see how long people are on the system without, using care. And for the most part, sometimes when I've done the analysis in the past, I looked at it, it wasn't a function of folks being out of state, they just weren't going to the doctor. Now, I think the Alliance situation is a lot more difficult because we can't, without a change in law, we can't terminate someone who hasn't used the system for a while. If they have a DC-1 card sitting there saying they're Medicaid eligible, I mean, they're Alliance eligible. So that's a challenge.
Yes. I think the question that I have is around the DC-1 card as like the form of, right? A DC-1 card is not a utility bill. A utility bill would tell me like, yeah, you paid for Washington gas in the cold of January versus something else, which is different, right? Not everybody has that per se. But I'm wondering if we need to look at the strength of the DC-1 card as a sole proof of residency in the district.
I think that would be spot on. I think the DC-1 card predates me, but as I understand it, it was viewed as a mechanism to aid persons who were experiencing homelessness to get documentation that allowed them to access benefits. Now, I think you're right. I think that it creates a hole in the system. And that hole is if you have a DC-1 card, you can go any state in the country and be gone until you decide you need some help.
Because my understanding is a DC-1 card does not expire.
That's my point. Yeah,
So
exactly.
it doesn't mean that you have to come back in and.
I think that's a legitimate area of inquiry for the council. We would certainly, something we would be willing to submit, a request for a policy change on, but it has to be done through council.
Okay. I will note that, and I would love to perhaps offline and not in sort of this very public setting. I want to dig into some of this data with you all more, not just on Alliance, but on Medicaid as well, right? Because if I'm just doing the pure math, so we had asked you all in pre-hearing responses, how many beneficiaries had never had a claim between Medicaid, Alliance, and ICP? And we were 13,000 people. Okay. If I'm just doing some rough math, that's 13,000 on Medicaid. I know they're not all on Medicaid MCO, but 13,000 times 8,400, that could solve some of our budget problems.
But
not to say that all of these people don't exist,
right,
but I need to know on our side before we start making some large programmatic cuts in terms of eligibility and otherwise, that we have done everything that we can to ensure that we're not paying for ghost people.
Oh, I think you're right. We should do that, but I would caution when you look at the Medicaid loss ratios for the health plans of the revenue they receive, now presently they're spending over 90% of it on medical expenses. So, if there's a large cadre of folks out there who are not using services and may or may not be in the city, it has not benefited the health plans in terms of their exposure for medical loss ratio. They are well over 90%. So there's not a lot of revenue that they're getting because people are not using services. And in some cases, they paid us back money because they've made too much money on a certain population. Now, if we take policy steps to limit the possibility that you would have a number of people who don't use services at all for years, sort of move them from managed care, then your managed care programs will fall into a death spiral. They won't be able to survive.
Yeah, you need some healthy
you
people
need
to
some-
sort of
that's correct.
offset.
That's correct.
Understood.
Yeah, and I
Again, mine is not around punishing someone for having not gone to the doctor,
Right.
although preventative healthcare is important because I don't want the first time you go to the doctor to be for some
absolutely. And
major medical event that
and-
could have been prevented. However, I don't want to pay for ghost people or someone who has is on our Medicaid services. They live in Maryland, but they pop over here every time they need
yeah, and
care.
we see eye to eye on that.
Okay.
And I would welcome, some offline discussions about how to deal with this, especially with respect to the Alliance.
Okay. In terms of on Medicaid fraud, healthcare finance investigated 141 cases of alleged Medicaid fraud in FY24. 14 were referred to law enforcement. While not a huge percentage in terms of total beneficiaries, you all shared that you've recouped over $2.2 million in overpayments. Has the agency identified any trends in terms of who is committing this types of fraud or the categories of providers where we're seeing this happen more often?
Yeah.
Sure. So we do an annual risk analysis for where we're seeing those trends, where we collaborate with all of our various stakeholders, the MCOs, law enforcement, the FBI, Mafuku, HHS, OIG, and others, to try and identify those. And then we publish or we produce a document on an annual basis that sort of identifies those trends. We can produce the risk analysis that we've conducted. If you'd like to take a look at that, I think the broad trends that we're seeing are going to be on behavioral health, telehealth, some dental, home health agencies, et cetera. But we have a document that breaks out the results of that risk analysis that we conduct with our stakeholders.
Okay. I would love to dig into
Sure.
that more. The categories that you named are the ones that I thought probably would be at the top. I think Director Turner, you had shared some document with me about the amount of money that we spend on audio only,
Yes.
which, sometimes you may not see somebody in person, but how far we have gone and the increase that we have seen on audio only behavioral health services where you don't know who's on the other side.
Yeah, that needs to be checked. You're correct.
I just feel like we need to check in on that. Okay. Now, one area that you didn't bring up where I guess we have sort of noted some cases were around personal care aides, home
Home health agencies. yeah.
health agencies. Okay, so that's sort of all in there under the EPD waiver. It's gone down from last year, but it's still a little high in my opinion. Is this normal?
Is what normal?
Well, 37%. So 52 cases of the fraud that you all cited or alleged fraud that you all flagged or investigated in FY24. Is that
Related to personal care aides?
yeah, is that a normal number is my question, I guess. None of it is normal, but like.
Yes, as always, things do tend to fluctuate. I will say the personal care aides remain a consistent concern. I think the DC Medicaid program has done a tremendous amount of work in the last decade to really get that program under control. It was a much bigger concern a number of years ago. But just the size and scope and sort of the nature of the services that we're talking about here always include various vulnerabilities and risks that just make them potential targets of fraudulent activity.
And this is even with the changes that we made around the geo check-in. I'm not saying it correctly, but you guys know what I'm talking about.
Electronic visit verification.
Yes.
And that gives us EVV is a great tool that we use in our investigations on these cases. It provides us a great data source. But it's a great data source sort of retrospectively. And so folks will still try and, bad actors within the system will still try and push the boundaries and not realize that we can track them through the EVV. And so it's our job to then use that data point to try and crack down on those occurrences.
Okay. When you all say that you refer the cases to law enforcement, are you referring it to the IG or straight to the U.S. attorney?
So we refer to the Medicaid Fraud Control Unit
Okay.
is our primary referral entity, and they then work with the FBI to build the cases. We conduct what's called a preliminary investigation under the federal regulations. They conduct with our assistance the full investigation that then goes to the U.S. Attorney's Office for prosecution.
Okay. I want to talk a little bit, just so you guys know, I'm getting there. Don't worry, I'm getting there. But your agency is large, you have a lot of money, and you do a lot of stuff. So, and unfortunately, I don't have any of my colleagues here, so you got to just hear me
That's all right.
talking. I want to talk a little bit about OAH and some of the Medicaid termination cases. So just so you know, in full transparency, I sent a letter to the chief judge this week. I don't even remember what day it was, but I sent a letter to the chief judge because at her performance oversight hearing, they talked a lot about the cases, the number of cases that they were getting, particularly in the public benefit realm. So some of that is, some of the challenges that they are having is not necessarily based on them. The cases, they don't bring the cases themselves. They were just adjudicating what is sent to them. And so, out of 202 administrative hearing requests that were filed on behalf of beneficiaries by the Office of the Healthcare Ombudsman, 114 had a hearing request around inaction or delay in processing an application or recertification for medical benefits. Now, for FY24, in terms of this delay in processing piece, was this a staffing issue or was this a technology issue?
When you said delay in processing, we're not talking applications, we're talking we're talking here, they were complaining about delays in.
This is delay in action or delay in processing an application or recertification for medical benefits. So this is related to, I submitted my application and you haven't taken any action and I've been kicked off.
Yeah, when we look at the data on, changes in the speed at which we are processing applications since the pandemic, the numbers have changed considerably in our favor. It does not mean that there are not legitimate complaints, but the percentage of cases that are now outside of the timely processing window have dropped substantially. But there are cases that would probably spur a hearing request.
Okay. Well, I mean, you might have improved on the timeline of
Right.
processing, but you have increased in the number of cases from healthcare finance that have gone to OAH. In FY23, there were 676 appeals for a decision that healthcare finance made. And last year there were 1,455. So almost doubling. And so I'm trying to understand.
Yeah, some of that's
What is
probably
leading
related, some
to
of that's
that
probably related to long-term care, I would assume. Benjamin, there's significant, I wouldn't say challenges, but there's significant complexities to accessing long-term care benefits because of the level of care requirement that has to be properly documented. And Benjamin can speak to those.
Sure. So for 2023, we had kind of breaking it into three categories: eligibility related filings, that's delay in recertifications and EPD waiver denials, terminations, and home health agency discharges. We had about 531 cases. So 5% roughly of the total assessment number. We assessed 10,640 folks in 2023. And that number was 875, 7% in 2024, of a total number of 11,697 total assessments. So we're seeing about 5% filings in that category. Then assessment related fair hearings related to reductions and folks filing on the long-term care side for unmet levels of care. That's a 3%. year over year, 3% in 2023 and 2024, 2%.
Okay.
So that's a set of the total filings in OH as it pertains to long-term care.
Now, is that an improvement or
It's a little bit of both. Since we exited the PHE and we started doing face-to-face assessments
Yeah.
in 2023, obviously the grievance numbers went up, but now
Yeah.
it's flattening out.
And that's a good point. That might, and as Darren just pointed out, when doing recertification, we obviously weren't, denying anybody anything. And so when we went back to the full process, that probably explains a part of the spike in the numbers that you're seeing.
Okay. So how many staff do you all have on the healthcare finance side who responds to these OAH complaints that are filed?
You mean?
By that, I mean, somebody is showing up on behalf of the Department of
Oh,
Healthcare
sure.
Finance at these hearings. So how many people are on that team?
Not enough. But Cheryl can talk about it.
Yes, I'm Cheryl Johnson, the General Counsel for the Department of Healthcare Finance. Let me just say from the onset, most of these cases are settled. The beneficiary doesn't show up. We have very few evidentiary hearings. In fact, we have one scheduled this week, but I would say we probably had less than 10 when we say a full evidentiary hearing. And so either the cases are resolved, most of them are from regarding long-term care in regards to the reduction in PCA hours. We have a policy. We don't litigate. We don't spend the resources to litigate cases in which there's a 2-hour reduction. We go ahead and settle that case until the next time that the next time when the next assessment is done.
Okay.
Yes, and so we mostly settle, and when we show up, as I said, we've only had less than 10 evidentiary hearings to deal with the merits of the case. And when I say 10 evidentiary hearings, that's for the whole spectrum, not only for long-term care, but also resulting if there is an issue.
When you say 10, in what time period?
I'll say 10 for fiscal year 24.
10, really?
Yeah, less than 10. I'm just,
Wow.
yeah, it's very few. When I say evidentiary hearings.
Yeah,
because
I
most
mean,
of the
they've gone
cases-
to the next step.
Exactly.
Yeah.
Exactly. When the cases cannot be resolved.
Right.
Less than 10 for, and probably we're thus far in fiscal year 25, the same thing, we'll probably have less than 10, even though we show up when we get a scheduling order.
Right.
And most of the time.
I mean, how many people do you have on your team?
I think there's 4, my deputy. I have 2 paralegals, 2 paralegals and 3, besides my deputy, 3 additional attorneys. No, 4, we just hired another one, but we have to show up just to make sure to represent the interests of the agency. But as I said, in most of the cases, it's a no-show, and we don't issue the scheduling order. The Office of the Attorney, the Office of Administrative Hearings issues the scheduling orders.
And if in the case of a no-show,
We
your
vote to dismiss.
okay, and your ruling stands or your
We
order.
vote to dismiss, and the OAH will send the final decision to the beneficiary. They can ask for reconsideration if they so choose. And we also have a process internally, reconsiderations. And so these cases sometimes don't go to a full-fledged hearing. We have a process internally where the beneficiary can submit additional information.
Okay.
And those cases, reconsiderations, I think, Melissa, Medicaid, yeah, they go to our Medicaid director.
All right. Well, that's good to hear. OAH started a whole public benefits task force because they have seen such an increased number, I guess, to Darren's point, post public health emergency, but they don't have enough ALJs. So they've got folks who've got caseloads of 800, 900 cases, in any given time.
And I think when they say public benefit, it includes more than just
Right.
Medicaid.
Yes. Public benefit, Medicaid, SNAP,
Yeah.
housing. Yeah. I think housing is part of that. And then, TANF, et cetera.
Mhm.
So yeah, the whole continuum piece, but when Director Turner said you don't have enough people, neither do they. But we're trying to understand what is spurring perhaps all the increase in number of cases that we're kind of seeing. On that, in the similar realm and talking a little bit about EPD, we'd heard from constituents that in FY23, healthcare finance was aware that at least 16 EPD waiver case management agencies, which served 96% of the fee-for-service EPD waiver population, had failed to timely submit and process their waiver recertifications. What actions did healthcare finance take to ensure that those case management agencies improved?
So we had, once we exited the public health emergency and went back to processing real-time applications, we put a process in place to work with each case management agency, technical assistance and training, making sure they had the full support for re-engaging their folks in completing applications and processing them timely. Where we found significant deficiencies with timeliness of submissions, we issued discoveries, and that triggers a process for corrective action, bringing them in, talking through challenges that they're encountering with meeting the requirements of the DCMR. I think it's 29 DCMR 4224 is what we hold them by. And we sort of go through what it is they're doing correctly, what they're doing incorrectly, and basically put them on the corrective action plan and escalate it progressively across the chain. So that's what we've put in place. It got better within the last calendar year in 2024. It was across the board, I would say. I mean, we have 17 case management agencies, and I would say maybe 3 or 4 were actually top performers that we didn't have to bring in. So it was an extensive process to engage with the providers to get them reacclimatized with the pre-PHE processes for timely submissions.
Okay.
Yeah.
Also on long-term care. So we heard some testimony during public witness testimony, and then of course it just continues to be an issue around providers reporting an insufficient pipeline of trained techs and direct care workers due to a lack of training programs in the district. Do you agree that we don't have a lack of, we don't have enough training programs? I mean, we heard from one assisted living facility where they are struggling to find people for these jobs to serve residents, whether it be LPNs, RNs, health techs, direct care folks. And I'm not sure if this is an appropriate question for healthcare finance, or should it be an appropriate question for the DMHHS, but you're here, same person, around whether or not we believe we have a sufficient number of training programs to improve our pipeline in some of these long-term care. Oh, you got to turn your mic on.
My viscera tells me it is not the presence or absence of training programs. What we have now is a very unique situation. We have high demand from a multiplicity of providers for the same skill. And the question is, how do we attract more people to that field? A lot of people are leaving that field for a number of reasons. It started during the pandemic, and I don't think that has completely reversed itself. So we could have all of the training programs we could fund, but we have to find a way to get people to be interested in the field. And I think that is the biggest challenge.
Why don't people want to be interested in this field, Director?
It is these jobs are very difficult.
I don't disagree.
They're very difficult. And you know, the pay is not bad in many cases. In some cases, it's not good. But in many, if you go work for a hospital or a community doc and you have skills as an LPN or an RN, you can make decent money. But the job is very demanding, and it became intolerable so during the pandemic. And a lot of people said, you know what, I want to do something else. I don't want to be this stressed.
Understood. And we
Yeah.
had that happen in sort of the hospital side of things
Yep.
too. But I think if you look at the population of the district,
Mhm.
right? it's aging.
Yes, it is.
And right now, we don't have enough people to support the things that we're even putting into some of these, right? We don't have enough PCA workers to
Yeah.
support the number of hours that someone has. That's why we have the
No,
My Way program and some of these other things that we have allowed for the flexibility on. And so I guess I'm wondering, like, what's our strategy on addressing this? Because it's only going to get worse.
Yeah, I think you have to go further upstream than the training program itself. And it may well be you need more training programs, but you have to go further upstream to identify a cadre of people who are good candidates for these kinds of jobs and see if you can inspire interest. Because right now the numbers are not good.
All right. I will say that we've tried on our end, right? We did a bill last year to allow for, I'm not gonna say reciprocity, but essentially folks who are licensed in Maryland and Virginia to be able to do that work here without having to go through the process.
Yep.
We've lowered the age to 16 because we had some high schools who wanted to provide this as part of their pre-professional nursing degree program. So right now, 16, you can't work in somebody's home, but you can do a summer job at a nursing home. And use that as a career ladder piece. And so I just feel like we need to be thinking more about what more we can do. Yes.
Just to add to that, we do have a $5 million grant through Money Follows the Person program. And we
Oh, yeah,
have,
that was my next question.
yes,
Go
so we have a capacity building MOA with the Department of Health to work on a high needs scholarship program for HHAs and CNAs. So we just signed that MOU about a couple of weeks ago.
Okay.
Yeah, so it's live now.
All right. Well, we'll check in on that. And you saved me a question. I want to ask about the Brown versus DC decision that came out on January 6th, that directed that the district must implement a transition assistance process for nursing home residents who are willing and able to receive care in community-based settings. I recognize that this was only a couple of weeks ago, but I'm
Mhm.
trying to understand where we are in the juncture of complying with this decision.
Yeah, the attorneys have advised, and Cheryl can talk about, the mechanics of it, but right now I think they're seeking a stay of the order. Is that correct?
Oh,
Once again, it's Cheryl Johnson. They're seeking to appeal the order. And so we're in constant communication with the Office of the Attorney General
okay.
as to the next steps.
All right, then we will pause on that while that goes through the process. Okay, so you mentioned the high needs healthcare scholarship program. Is with regard to CNAs and HHS, that's not the only place that you collaborate with DC Health on this program, correct? Go ahead. You want me to take a poll pause? No, I think someone else can, but I think it's kind of weird to keep going when you're not here. So why don't we do this? Why don't we take a 5-minute break and then we'll come back. Okay, and we're back. Still on long-term care.
Okay,
I want to ask about Comagin. We had several groups who testified last week that they saw sharp increase in requests for assistance to challenge improper reductions of nursing or care services, which coincided with when Healthcare Finance's contractor CoImagine began implementing the Interqual assessment tool, to make medical necessity and hours of determination for long-term care benefits. I'm curious, what is the oversight that Healthcare Finance is doing with CoImagine to ensure that, one, their assessment tool is proper and is working, and two, that beneficiaries are receiving their appropriate level of care?
we watched that very closely, and I'll let Benjamin, tell you about the interaction. It's one of those complicated processes, but it's one that we take very serious.
Okay. You turn on your mic, Benjamin.
Yes, so we have, we followed the guidance for the inequality criteria for assessments. And the clinical criteria are pretty much set across the industry. And we have regulations that speak to our skill benefit and also our PD and benefit. And what we do with Comagine is a regular review with them. We go over not just the utilization reports, also what approvals, denials, and any service determinations that have been made. So we meet with them monthly to go over the numbers that they're looking at. We also have a process for administrative review that Comagine does. And the team, through the contracting officer over at DHCF, along with the long-term care administration, during those regular check-in meetings, we go over any issues or challenges that they're having. There wasn't a change to the requirements of how we assess folks for skilled services or PDN. We simply applied the existing regulation. For PDN, there's a technology dependence criteria that has to be met, along with the submission of additional documentation by the requester.
So here's my trouble. When you said you didn't change anything, I think we had somebody who testified that the client was blind. Nothing changed about the client being blind, and yet we reduced their hours on services. So something changed because nothing physically about the health of that patient changed.
So I'm sorry. So just splitting those two, I think that testimony was about reduction of PCA, not skilled services. So for PCA, we have the appeals process where we do the assessments on an annual basis every 12 months, or if there's a change in condition. The requirement for 12-month assessment is what we have written in our waiver. And it's a standard that says we have to assess folks at the minimum every 12 months. So if I'm recalling correctly, the case that was referenced last week was about a beneficiary who experienced a reduction despite the condition not changing.
Right.
So the determination for reassessments has to happen every 12 months for the face-to-face clinical assessments. So we simply went by that process to reassess the beneficiary. And in the event that there was an adverse action taken by way of a reduction, we put forward the process for appealing that decision through.
Right. I know that there are the processes for it, but in that case, on its face, right? I was blind 12 months ago. I am still blind today, but now you're saying I require less hours.
So it's the clinical determination that determines that, which we have an independent third-party assessor making that evaluation. So while we don't have the full details of the case and what other issues may have presented itself on the clinical side, without looking at it in front of us, won't be able to speak directly if that was just the only issue.
Okay. In hearing that, I had to wonder, okay, if nothing has changed about the person's physical care, then something changed about the assessment or the assessor.
Nothing has changed on the assessment or the assessor side. So the blindness may not be the only issue that may have been presented during the assessment. So it's a clinical determination criteria that the independent assessor goes out and evaluates each face-to-face assessments when they complete it.
Okay.
And to the extent where there is a finding that leads to a reduction of scope of services, that will be based on the clinical determination made without seeing the full presentation of that case.
Mhm.
It is a clinical judgment made by the third-party clinical assessor.
Okay. Healthcare finance overestimated its budget for private duty nursing by about 9 million in FY '24. Was this variance due to a reduction in private duty nursing hours or something else?
When you look at our provider payment budget, when you look at fee-for-service care and you look at our skilled nursing line, as we analyze costs and shifted from post-pandemic, and we look at trends when we determine what costs are needed, when we looked at private duty nursing and determined what the budget would be, looking at historical trends, we estimated what we thought that would be. What we also, when you're looking at those skilled care services, we also try and estimate who's going to be in dual choice, Medicare Advantage, because you have EPD component under the Medicare Advantage program, and we try our best to determine where our population that's in the EPD will land.
Okay.
And then we budget accordingly. And sometimes we can get it right that they're in EPD, but maybe not where they're actually utilizing services, whether it's in Medicare Advantage or whether it is in our fee-for-service program. And I'll just also say, when looking at our fee-for-service budget, while we trend based on historical patterns and we try to make adjustments, it's important to understand that historically someone could have used skilled nursing. But in the current year that we're looking at, they may shift from skilled nursing to another service. We may see it in PCA. And so when we look at our fee-for-service budget, we don't only look at what appears to be overspent. You also have to balance it with the other fee-for-service
Mhm.
categories that were utilized because they offset each other.
Okay. In terms of the 3 long-term care assessment contracts, Liberty Health, Telegen, and Guardian Track, I think I'm saying that right. Did each contractor meet their goals and outcomes for FY '24?
So Telegen is new, is relatively new. Their
Yep.
contracts started on February 1, 2025.
Okay.
Guardian Track they're currently functioning as our FMS, our fiscal management service vendor for the self-direction program. And they met their requirements for FY '24 based on the audits that we concluded last year. And for Liberty, the outgoing LTSS independent assessment vendor, they did for '24 also.
Okay. There was a lot of conversation last week about the need for the district to apply for the 1915J self-directed personal assistant services waiver. We heard from witnesses that they feel like this could help us save money or alleviate some, not all, but some of the burden of the workforce. And that I think our neighbors, both in Maryland and Virginia, have applied for this waiver and use it. What conversations have you had or not around applying for this waiver?
We have talked internally, and Angelique can speak to it more about the value of it. I don't necessarily subscribe to the fact that it'll solve the workforce problem. That doesn't, it won't create more workers. It'll just move them from one environment to another. The big question for me, and whether I would go to the city administrator with a budget request for it, is whether or not it will in fact save us money in a stressed budget environment. Would we spend less on this service that we now spend? And I think that that deliberation is still being had internally. And Angelique, if you don't have something to add, you go ahead.
First, I want to start when we talk about workforce issues and concerns. I am not a part of the group that believe that we have a workforce issue with home health aides. I do agree with skilled positions such as nurses, RNs, LPNs, but not home health aides. I think between the home health aides that currently work for our providers, the home health aides that have, that are available through, staffing agreements. And then you have the people who are part of our participant directed services. Between those three areas, we've seen an increase in the number of aides that we have. Where I think beneficiaries see a problem and associated with the workforce issue is when you have the off hours. If you remember back during the testimony, you heard people complain about the 8-hour cases versus the 6 hours.
Mhm.
And I think right now PCAs are able to choose what cases they're allowed or that they will provide services to, what they will accept. And that's what's causing, in my opinion, and in the review that we've done, the issue with beneficiaries not being able to get the services. It's the difficulty in when a person works in a facility, the CNA who's providing care in a skilled nursing facility, they can't tell the skilled nursing facility, oh, that's not an 8-hour case, so I'm not going to accept that case.
Mhm.
Whereas in a home setting, they're currently able to tell their provider, that case, I'm not going to man that case. It's not sufficient hours. And then it requires the provider to try to figure out how do they man those off hours. So I just want to preface it with that. I don't think we've seen an uptick based on the enhanced wages, some of the training efforts and the flexibilities that have occurred. Related, I forgot what the question was.
The 1915J.
Yes, and so when we think of expanding participant directed care, the first thing that I would say is that is one where we've seen it being abused. I won't necessarily say fraudulent, but we've seen it abused and not utilized in the way that it was anticipated. DDS has established a program very similar, but they had the benefit of learning from our mistakes and how we implemented it. And so expanding it to address an issue that isn't there, workforce shortage, I don't think that's the resolution. I think you increase the chances of potentially increasing the waste that we have. And thirdly, it could be looked at as an independent waiver that you would utilize, not as necessarily a state plan, but also looking at it as a waiver with more restrictions and more specific populations, similar to how DDS implemented, similar populations that can benefit from having someone that can provide that level of care. And I'll turn it over to Benjamin.
No, that's helpful.
sufficient?
Yes,
Okay.
yes. I'm over my time. We've been joined by Councilmember Matt Freeman from Ward 3. Councilmember Freeman.
Thank you very much, Chair Henderson. It's danger in coming in, close to 5 hours or 5+ hours into a hearing. So I want to
Wow,
be
we've been
careful.
here that long.
So I'm going to try to be careful not to cover territory that has already been covered, or at least not to try to take it too deep. I now chair a committee with oversight over DHS, and you have a linkage around DCCAS. And I know there have been questions about that already. One thing that I'm curious about is what kinds of things you're exploring to improve the DCCAS system, and to what extent could AI be a tool in supporting that system or systems of records management that the district is using?
Well, and I'll let Tamika speak to, I'm not qualified to speak to the potential application of AI, though I assume that somebody could find some use for it. DCAS has, we've come a long way with DCAS, and certainly there are things that we still need to do, but it is not an ineffective system. It is probably a bit more complicated than DHS would like, but it's actually do a lot of things. And it is difficult to build a system to do all of those things and still have it be, you know, a very simplistic point and touch for and get everything done. It's very difficult. But we do work, we do hear the concerns, and Tamika can talk about anything that we're trying to do to make it easier to use for some of the users.
Good afternoon. So in regards to the AI technology, what I will say is we do not currently have full guidance from our oversight organization, particularly FNS, on utilizing full AI technology, but we do have what we call some enterprising technologies that we are working with DHS on that are basically, if we have at least 3 initiatives that we've been working on to kind of support them when it comes to actually matching data to ensure that when information comes into DCAS, there are other systems that DHS also has to use in order to process a case fully. So in order, when this information comes in, we're able to match those verifications or match that client information to those cases so that DHS can process. We have some of the address verifications or some of the address work that has happened that we are supporting DHS on. We actually have a partner for Code for America that's working on some tools that will help our systems talk to each other a little bit more. So we are using these emerging technologies to help and support us across both agencies to ensure that we can make it more seamless and more efficient for DHS to determine benefits for their programs.
So when you had a reference to your guidance from FNS.
So the Food and Nutrition Services, they oversee, DHS and SNAP. And so we have to adhere to their rules, and CMS has also put out some guidance. And so we have to make sure that we are adhering to the mandates and when it comes to AI technology and how we're using it.
Wonderful.
And I would add that Octo has sort of taken the lead on guiding agencies on the use of AI across the HHS cluster. So we sort of rely upon them to appropriately guide us in ways that will result in, if we need AI, an efficient use of it and not a waste of money. Yeah.
All right, wonderful. Thank you very much. I believe that in New York, they may be doing some things using AI that they feel like has had benefits, but that's a thing we'll look into with Octo. In the pre-hearing responses, and you may have covered this, that the Office of Healthcare assisted folks in filing appeals with OAH, and there were at least 6 that were SNAP. And I wonder to what there's an increasing call for a public benefits ombudsman, and there's a healthcare ombudsman, and here you have it that work happening touching SNAP. To what extent does your work, do your folks help people with other appeals in the ESA space?
Well, and in my role as deputy mayor, I try to resolve, if I can, any issue that comes across my desk, whether it's SNAP, TANF, Medicaid, Alliance. But on the appeal side, you know, I don't see where we would need a separate benefits ombudsman, because I think, you know, there's sufficient attention to those appeals as they arise that, you know, I'm not sure what added benefit another ombudsman would do. Now, if you make the argument that the appeals are so numerous that, you know, one person, one FTE can't handle them, that's another question. But I don't know that any appeals about SNAP or TANF or other matters are beyond the scope of what we currently do.
And that was my question, whether or not you felt that you had the authority to be operating in that in the ESA area, or you thought that you were limited to the Medicaid area.
I mean, I'm not, but I know is Marty here? Our ombudsman is not here, but she is one of the most effective that I've ever had the pleasure to work with. I will check with her and see how she handles complaints about SNAP and TANF and get back to you on whether she believes that's something that is a gap in the current system and needs to be addressed.
So at a hearing a couple of months ago, we had a hearing about PIW.
Right.
And one of the questions that came up was the staffing levels and whether or not they were at appropriate staffing levels. And there was a little bit of back and forth about, there's no mandated number, but then there's a mandated guidance of what it's supposed to be. To what extent are you reviewing staffing levels at PIW as part of approving payments to PIW?
Yeah. We don't review the specific staffing levels for any provider. We just try to make sure that they're providing quality care based on we try to understand how they're delivering care. If there are complaints about the quality of care, then DC Health will get involved, and DC Health will evaluate what remedy is appropriate if a provider, be it a hospital or or a mental health hospital like PIW, whether they need to increase staff. But we at DHCF we don't get involved in that.
So if there are complaints, then you would count on the Department of Health to look into it, and then they might make a recommendation about.
Absolutely. Yes.
Okay. So wrong hearing. I think that I had a number of questions about encampments, but I understand that you did that all this morning. And so I think, and probably not the right place for that, but thank you very much. I just wanted to drop in because in the new role that I'm in, I do expect the DC CAS system to be a major focus. And so
Sure.
you may be hearing more from me over time as we're looking for ways to strengthen that system.
Sure.
Thank you.
Absolutely.
Thank you, Chair Henderson.
Thank you, Councilmember Freeman. We did cover encampments during the DMHHS portion, but we're happy to share any follow-up information we get with you on that as well. All right, I've got 3 more topics.
Wow.
Youth, maternal health, and behavioral health. That's it. All right, then we're done.
Okay.
Youth is only one question.
Okay.
All right. So we're hearing a number of complaints or issues in terms of youth who had previously had Medicaid coverage. They entered the juvenile justice system and they need to be re-enrolled in Medicaid once they are exited from the system. But we hear lots of delays in terms of getting that turned back on. Now, in the DOC system, there's a specific process of if a person is about to be released, that Unity Health is already starting that paperwork in order to get them on to Medicaid services before they are discharged. I'm not sure if that's happening in the DRS system, and so I wanted to ask about that.
Yes, so my staff specifically in the Division of Eligibility Policy have been working with DRS staff during the period of the pandemic. What happens is they're supposed to send over a form to us when folks come in specifically and when folks go out. There was a interruption in that process based on some guidance that was sent out from us. I would say a misinterpretation, but there was just a miscommunication about the sending that paperwork to us so we can field it over to DHS and get it processed and get the I codes updated in the system, everything turned back on when folks are leaving.
Now, is it a physical form or is this something that I could do in the internet?
I think it's like a 1208 form. I don't want to get the number wrong, but it's a form you can send it to us electronically.
Okay, that's what the question
yes,
is. Like, do I have to snail mail it over to your office?
You do not.
Because that would be.
You do not have to snail mail it over to us. That process, my team is working very closely on, making sure that process is adhered to and restarted. So the problems folks have had about the DRS I codes being applied and taken off timely, those should be coming to an end.
Okay. All right. That's good. Like to hear. All right. See, look at that. Down to now two more topics. All right. In the pre-hearing responses that you all sent us back in January, you said that there were 17 active doulas or doula groups And that the total fee for service reimbursement for the doulas was $0, with the rationale being that most of the doulas are likely contracting with or receiving reimbursement through the managed care plans. Have you all confirmed how many of the 17 doulas are actually contracting with each MCO?
I think we could. I don't have that information right in front of me, but I think that's something we could follow up on.
Okay. I think y'all know how I feel about the doula piece, but also too, to say that we have 17 doulas, but the 17 doulas aren't actually contracted with our MCOs, that means that we really don't have 17. Does that make sense? So I want to understand that part.
Yeah, we'll get that to you.
Okay. We heard from a witness last week that she provided doula services for 8 months without pay because the MCO she was contracted with did not have, quote, doula modifiers on their provider portal. In terms of us rolling out this now doula benefit, how do we ensure that MCOs have the proper code modifiers to ensure timely payment to providers?
I'll let Lisa.
Okay. I love how y'all tag in. You're like, oh, not me. That's her.
And I'm sorry, could you repeat the question?
Sure. So we had a witness who testified last week that she provided doula services for 8 months without pay because the MCO she was contracted with did not have doula modifiers in their provider portal. So how is healthcare finance ensuring that MCOs have the proper code modifiers in their portals to ensure timely payment to their providers?
So the fee schedule is updated that has the codes that are covered for doula services. I believe a transmittal went out to the provider community, the Medicaid provider community that spoke to the services that are reimbursed through Medicaid for doula services. The health plans interact with us. You know, they confirm that information when we send it out. If they have questions as to how they should apply it within their systems, we discuss that with them as well.
Okay. I'm gonna ask this again, but like, do we do a confirmation that you have in fact updated your portal? Because it's disheartening, the idea that someone worked for 8 months without pay because the portal didn't have the code in order for her to be paid. That makes sense.
It does. The specific health plan actually had set up the reimbursement process for doulas to submit their claims for reimbursement. I believe this was like a first time submission and it was at the start of the process and there were some kinks. And so they worked collaboratively and attempted to work collaboratively with the doula to resolve the issue. The doula was given instructions on what she needed to do in order to move the process along. And so that was a part of the delay, the ability to collab and make it happen and get to where they need to get to.
Have you all heard any further complaints about the rollout of this particular benefit?
Not necessarily complaints. I mentioned earlier that the health plans were covering some form of doula services before it became a Medicaid covered service. And with that coverage as a value add benefit, there wasn't a lot of utilization. And I believe if I'm wording it correctly, the programs that were offered by the health plans were a bit more, I guess, robust than what is being offered as a Medicaid covered service. And so there are some situations where doulas have been hesitant to enroll because of the enrollment process. Also, health plans have outreach. We let them know the number of the names of the doulas that have enrolled with us. Sometimes when they reach out to them, because of the process, they're not accustomed to having to go through the enrollment process with the Medicaid agency. So sometimes there's some hesitancy with that. But I do know that although services are covered, that the health plans still have relationships with some of the doulas still outside
Of the plan. Got it. Okay. I mean, I've been thinking about something that you said earlier, Ms. Stewart, around how some constituents or enrollees might say, well, this isn't my first pregnancy. And then my thought and hopeful response that the MCOs are giving is that not every pregnancy is made the same or equal. And I also recognize too that there is certainly choice in all of this, but when I look at our maternal mortality numbers, and then I look at the number of folks who are not seeking prenatal care, I'm like, there are linkages here. And I know we cannot make someone drink the water, even though we have brought them to it. But I feel like we need to be continuously pushing out this educational message of like, yeah, this could be your third child. And you know what? The fourth one is going to be completely different than your last three. Why not be prepared, you know?
Yeah, I
Um,
agree.
Okay.
Having worked on the health plan side before, I can tell you that some beneficiaries will say, you're my insurance company, you're telling me what to do. If my provider isn't telling me what to do, then they don't see it as important.
Yeah.
And so that's where obviously the relationship with the health plans and their provider networks, like they have to be partnerships and supporting the efforts to get the beneficiaries to be interested or to invest in their self-care.
Yeah. Invest in yourself. Yes. One of the things that we talked about last year with the perinatal mental health task force was, and just overall, when we were having conversations around maternal health, was that healthcare finance was planning to reconvene its health advisory group. Did that happen?
Who was the person for this?
I know it technically would have been Melissa, but Eugene, I guess.
I think we reconvened and met once early in February 2024, I think is what our oversight response says.
Okay.
And I think looking to get that back more consistently in this current fiscal year.
Okay. Has the Institute for Medicaid Innovations Doula Learning and Action Collaborative begun?
I'll let Joe Weisfeld, our innovation director, take that one.
Okay.
Good afternoon, Madam Chairperson, Joe Weisfeld. I'm the Director of the Healthcare Reform and Innovation Administration, DHCF. So your question on the IMI Learning Collaborative, it has started, and there are a few members of my team as well as other members across the DHCF that has been participating in it.
Okay.
We also, I know at the hearing last week, you had some comments around the Transforming Maternal Health initiative that we were awarded.
Oh yeah, that was going to be my next question around that work.
There are linkages there.
Okay.
One of the requirements is around standing up a doula advisory committee. And so we've already had conversations with the leadership of the Working Health Council and my group to coordinate and work with them on that component of it.
Okay. Now, not to belabor the point, but it must be noted that one program strand, at least in my understanding of the TMAH, is home visiting.
It is an optional element.
Optional. Okay. Are we doing home visiting anymore?
So with the way the program is set up, the optional elements in the first, or all of the elements of the opportunity include milestones that we have to meet.
Okay.
For all of the mandatory elements and milestones, we know what those are. CMS has told us. For the optional ones, they have told us that they will share that in the first year of the program. So we don't know what that involves at this point.
Okay. All right. We'll check back in on that. I guess this is a question for Eugene, maybe. So CMS approved our SPA for IVF. Yay. And noted in the pre-hearing responses that 26 beneficiaries have already taken advantage of this program eligibility in FY24, which is great. Do you all have that number broken down by Medicaid versus Alliance, or is it just sort of all together?
I think we'd have to get back to you on that one.
Yeah, we can get the number.
Okay.
And for IVF SPA, you mean the
drugs.
The drugs. Okay,
Yes,
perfect.
sorry.
Just wanted to be clear. Yep.
Yeah.
Sorry. The drugs, not the whole enchilada. Although I don't know. Our other neighbor on 1600, he might say everybody gets a kid. We'll see. It's kind of expensive. Okay, behavioral health. So, providers spent the last year anticipating this behavioral health carve-in. I think DBH even did some reorg in their work around the Access Helpline and other things because they were anticipating that MCOs would be taking on some of this work. I did not move forward with the carve-in due to financial reasons. But we're hearing increasing number from the Behavioral Health Association and others that no one has provided a timeline of, are we just pause or we're not going to do it forever? And if we're not going to do it forever, how do we put the services back at DBH that they let go of because they thought the MCOs were going to be doing that work?
Well, the issue of are we going to do it is become highly dependent on the budget, obviously. It was the $13 million pressure when we stopped it. My fear, given the rate increases that we gave across the board for mental health providers, that number is going to increase substantially. So it is difficult to give a timeline as to how we, when we might do it. There's certainly a desire to have the behavioral health carved in, but right now with the challenges that we see financially, it's difficult to say when that can happen.
Okay, so in the difficulty of seeing when it happens, now I'm going to ask you to put your deputy mayor hat on, but also no, it could actually be your healthcare finance piece. There were functions that were happening at the Department of Behavioral Health that they are no longer doing in the way that they were because they thought that the MCOs would take it on. So what is our plan to help try to turn those back on at DBH so that there's not a gap?
Well, I think when we, and this budget season will tell a lot. If we can't get it done in this budget season, then we will have to go back to DBH and their providers and say, look, this is not going to happen, certainly in 26 and maybe not in 27. And if the federal match stuff goes through, it may die a permanent death. So we need to figure out operationally how to get those services turned back on post haste. And that's something we will do once we get clarity on what's going to happen in 26.
Okay. So we'll check back in on that during the budget process. I want to give these providers some clarity.
No,
A lot of them for whom spent money on the front end having to put in certain systems in place in order for them to be eligible to contract with a MCO.
Sure.
And now they're just kind of in limbo land. And we need to just kind of figure out what's going to happen there. So in sort of following up for the conversation we were having earlier about the Medicaid fraud piece and then on audio only telehealth, it's up nearly $40 million on that. How are you all addressing that spend? Or, I mean, I want to call it an audit, but like basically how are we verifying that it is legit, but also controlling the growth of that particular service line?
Yeah, I think we are looking hard internally at going in the direction of rolling that particular benefit back.
Okay.
In addition to that, I know our program integrity office, we have a person that is assigned to behavioral health. But under the leadership of Kevin, they've looked into some of the concerns around the utilization and have worked with the powers that be to make sure that that's controlled. DBH and DHCF have also worked together to look at the utilization trends, when it's appropriate to use visual telehealth, when it's not, how should audio be utilized? And DBH is currently, we've implemented some controls in the system, but DBH is also working on policy updates to make sure that we control that abuse and that we align it with medical necessity as well.
Okay.
And that should bring down the abuse of the telehealth.
Okay. I just want to note too, for the record, from our last conversation about Medicaid renewals, that the number in terms of applications that had been processing for a long period of time has decreased significantly. And so I want to give kudos to the staff, both at Healthcare Finance and at DHS, for the work that you all have done to bring that number down. Still high, but better. So I want to give praise for where it is. I think from your earlier slides, Director, where you talked about we saw a decrease in enrollment and then it shot back up again. Well, we're not nearly where we were in terms of the public health emergency, but like the population of the district hasn't grown that much for us to now seeing all of these new Medicaid eligible folks who are coming in, what are we attributing this increase in enrollment to?
Well, they may not be new residents. They could have could even have a prior history in Medicaid. Got off, got a job, didn't work out. They come back on Medicaid until they can get themselves situated. Some of it's probably new growth, new entrance into the city, but that's some of the churn you see in eligibility processing for Medicaid in general. Now, our churn is probably a lot less than what you see in states that have a much lower eligibility levels, because in those states, the frictional turnover is pretty high because you can get a part-time job and all of a sudden you're no longer eligible for Medicaid. Here, you got to actually really make some money to get thrown off Medicaid. And so I'm guessing that increase, and it's not quite back to where it was pre-pandemic. It's close though. Pre-pandemic, 303,000 total. We're now at what, 294. So it's coming back. So I think some of those people, maybe had an opportunity to do something else, didn't work out, and they sort of back on Medicaid. But that, that's, I'm thinking as you asked that question, how can we take a deeper, we can certainly look at some of the folks who've come on since the pandemic and then look back at our claims data and see if we have records of them using the system in prior years. I think we will do that.
I mean, this is what I'll say is sort of in closing and kind of forecasting in terms of the budget. I recognize it's going to be a tough budget year. I feel like all of my colleagues, my cluster will get hit the hardest.
Yeah.
Whether it be federal stuff or just otherwise in terms of pressures and whatnot. And I accept that as a challenge. What I don't want to be in a position of doing is accepting draconian or dramatic cuts to the Medicaid program without having information to back up why we're doing it.
Yeah.
In terms of communicating it to the public about, this is why we're making this change. This is what we feel like the impact is going to be. And this is how we're going to continue to address our most vulnerable residents within the realm of what we have.
Yeah.
So to the extent that we are able to, and this is why I was bringing up the questions earlier with the public integrity team and otherwise, is like, I want to make sure that we have shook every tree, shook, you know what I mean?
I know what you mean.
Shaped, shook, whatever. Same difference. Looked under every rock to ensure that before we have to take some massive eligibility deduction, that we are finding the savings for perhaps that we have missed.
Yeah.
In going forward there. I think we all have some follow-up questions on some of the things that we wanted to get some pieces on. I think in a different setting, we need to probably have a different conversation too around, we'll talk the Alliance program, but I also want to talk about the behavioral health specifically on substance use, and some of the medications there. You know the emails I'm talking about.
Yes, I know the emails you're talking about. And I will say, we have raised the dosage limit to pretty much as high as we can go. That doesn't seem to satisfy some of the complaints. But yeah, we can certainly have the discussion.
The dosage part is one of it. The other emails around how and who is doing the oversight over various MAT locations.
Right.
And now I know that is a combination between DC Health,
Yeah.
DBH, and otherwise, but the complaints have not gone away.
Yeah.
They have only gotten louder.
Well, we can certainly have that conversation. I think if there's more that we can do, we will certainly do it. I don't expect all the complaints to ever go away, to be honest, but we certainly can have an informed discussion about what needs to be done differently. Because if we're not opposed to making changes if it's going to improve service delivery. That's not, we don't. There's no profit to us to have people disgruntled with their health care. So we always look to try to change the system in ways that give attention to their concerns while at the same time respecting the stewardship we have for the benefit. So we're more than happy to do that.
Okay. All right. That's all the questions I have for today. I appreciate all of you, your attentiveness. To the public who is watching, if I didn't get to your question, how long have we? I don't know. It's been 6 hours.
I think you got to all of them.
I'm trying. I'm trying here. Okay. So Thank you to the public witnesses who testified last week. Thank you to Deputy Mayor Turnage and his team for providing testimony and engaging in what I feel like was a very robust conversation and discussion. For those who want to submit written testimony, you can certainly do so for the record. The public testimony will be accepted until February 26th at 5:30 p.m. You can submit it on the council's hearing management system website at dccouncil.gov/hearings. The next performance oversight hearing for this committee will be on Monday, February 24th. We'll hear testimony for the public witnesses for DC Health. I want to just mention, because this is a little something we're trying different based on feedback. If you are signing up as a public witness, you have 2 time slots you can choose from. You can sign up either for the hearing to start at 10 a.m. or you could sign up for the slot that starts at 3 p.m. We're trying to accommodate individuals who cannot do it in the middle of the day. Let's see if it works. The government portion for DC Health will be on Wednesday, February 26th. And then as I alluded to, in March, we will have a hearing with several of our licensing boards, as well as our Medicaid MCOs as well. All right. And so the time is 2:14 p.m. and this hearing is adjourned. Thank you all.